I think Swadhanaya, you can start.
Yes. Should we start?
Okay.
Yeah, now we can start.
Yeah.
A very good evening to all respected dignitaries and my dear colleagues. Indian Fertility Society Vidarbh chapter, in association with Nagpur Obstetric and Gynec Society, presents the 30th series of sizzling Master Stroke Fertility web series. First of all, we'd like to wish you all a very happy Makar Sankranti. So, first, today I, Dr. Neha Verma,
and I, Dr. Swadha Kutpallivar,
will take you through the brainstorming sessions of the poor responders. We'll be balancing the quality versus quality in poor responders. Poor responders represent more than a third of women undergoing assisted reproduction. Typically, they are the patients with advanced maternal age and low ovarian reserve. However, there is a younger group that unexpectedly demonstrates the impaired response to controlled ovarian hyperstimulation. So we will be hearing from all our experts and each and everything about poor responders.
let us seek blessings from Almighty. This is a symbolic moment that signifies dispelling of darkness and igniting of thought and enlightenment. It is my honor to invite dignitaries for digital lamp lighting. Neha, there is no music. There's no music, Neha.
Okay, okay.
You have to reshare. By add when you reshare. They will ask that join by audio also.
Okay, okay.
Join by audio, only PPT will come.
Or Swada, should we go ahead or will?
I think we'll go ahead, Swada.
We'll go ahead.
Okay, ma'am.
Yeah, go ahead.
That's what I'm telling.
Yeah. I now take pleasure in inviting our very dynamic secretary, IFS Vidarbha chapter, who's also president of NOGS, Dr. Sushma Deshmukh, madam. Her zestful tenure is filled with loads of academics and learning. We welcome you, ma'am, for your welcome address.
Thank you very much. A very good evening to all. Happy New Year. It gives me New Year's fresh feeling to welcome you all for today's sizzling Master Stroke series of our IFS Vidarbha chapter with our Nagpur Ovarian Society. Friends, this is our 30th Master Stroke. With New Year resolutions to give best services to our patients, New Year declaration to pursue advanced scientific content, New Year's dedication to follow pious path, New Year's determination for our own good health, and most important, to have tons of friends, but to remain in touch. So, the today's theme is poor responders, balancing quality and quantity. So, today it is reminding me the pious Kumbh of Amrut, the Amrut Kumbh of infertility. To treat an infertile couple, we require acumen, brilliance, caring, and compassion, with prayers and respect. Dealing with poor ovarian reserve is very challenging. Will create a lot of confusion. You will make you feel down, and you keep on searching for the exact solution. So we are opening this infertility kumbh of New Year. The first Amrut drop of this kumbh is acumen. Jatin Shah. Jatin means Lord Shiva, Shubha. Dr. Jatin Shah is renowned IVF consultant. Will be speaking on clinical management of poor responders. And everyone requires this acumen. Welcome, Dr. Jatin Shah.
Thank you.
Our second drop with this kumbh is brilliance. Varsha means rents, nutrition. With the brilliance, Dr. Varsha Samson Roy will be speaking on laboratory strategies for poor responders. Welcome, Dr. Varsha Samson Roy. Our third drop of kumbh is caring. Dr. Manju means beautiful, lovely. Dr. Manju Jila, I know her since many years, an amazing academician, is going to speak on ovarian rejuvenation procedures. So there's a caring of ovaries. So we have completed ABC, acumen, brilliance, and caring. Welcome, Dr. Manjujila. Apart from this ABC of Amrit Kumbh of infertility, we require dedication and efficiency, D&E. Dr. Nitin Lad, a dedicated IVF person. I think Dr. Neha Lad will be there. So she is also dedicated IVF lady. And Dr. Sangeeta Sharma, efficient IVF lady, going to chair this wonderful session. Welcome, Dr. Nitin Lad or Neha Lad and Dr. Sangeeta Sharma. Too young, fantastic. Too young. Now we have completed series now the F and G. Two young, fantastic and gorgeous, sweet girls of this Kumbh are collecting all these words of wisdom in a systematic manner as a MOC. I welcome to audience, friends, seniors to witness this drops of Amrut on the occasion of this upcoming Makar Sankranti. Lastly, my two secretaries, Dr. Bindu Chumate and from IFS and Dr. Pragati Khadkar from the NOGS are the honored, H for honored, and the intelligent ladies of this Kumbh. So let's enjoy this webinar as we are decided to have tons of friends in this year and keeping in touch. So, Tilu Gya, God God Bola. Happy Makar Sankrant advance. Thank you very much.
Thank you so much, ma'am, for such a lovely and unique welcome address. We are lucky to have presence of chairpersons for today's session. We have Dr. Neha Lad, madam. She is a leading IVF specialist practicing at Navjeevan Hospital, Nashik.
And we have Dr. Sangeeta Sharma, ma'am, which is a center head at Jaipur. She is associate professor at Department of Reproductive Medicine, and she is the past secretary of IFS Rajasthan chapter. Ma'am, we welcome you all, and please, you can go ahead from here.
Thank you so much, Dr. Swatha, for the kind words. And it's actually my pleasure to be a part of such a wonderful webinar, of such a wonderful Masterstroke series. So we have Dr. Jatin Shah with us, like Dr. Swatha just said, and Dr. Sushma just said. Without wasting time, let me just do the formalities to introduce him. Everyone knows him. He's a specialist in assisted reproduction, and he's done his MD and DGO as a gold medalist from Mumbai University. He's the director, Mumbai Fertility Clinic and IVF Center. He's established more than 20,000 successful IVF pregnancies over the past 30 years, and he has helped establish the first IVF-VC pregnancies in UP and Kerala states. He has co-authored the book on photographic atlas of gynecological and obstetric operation procedures, techniques, awarded for the best paper presentation in National Foxy Congress. He has pioneered the setting up of IVF centers in many cities across many states, more than 500 national and international presentations, guest lecture, keynotes, and orations. He's the founder member of Asia Pacific Initiatives for Reproductive Endocrinology, and he has numerous publications in journals and texts. So we are so honored and pleased to have you with us here today, Dr. Jatin Shah, and he would be speaking on the clinical management of poor responders. So over to him.
And one more feature I would like to add, he's a wonderful photographer. He captures beautifully.
And you would see that in his presentation as well.
Yes,
it
yes.
would be there. Yeah.
And he has the eye for beauty in everything.
Singer also, Bindu.
Yes.
He's singer also. Very good singer.
Yes, very good singer as well.
Chance to listen to song.
So multifaceted personality there.
No secrets left now.
Now you make people sing. Okay. So over to you, sir.
Yeah, just sharing my screen. Thank you so much, dearest Dr. Sushma, Dr. Bindu, Dr. Sangeeta, Dr. Neha, Dr. Swatha, of course, chairpersons, my dear friends, Dr. Nitin Lad and Neha, of course, and Dr. Sangeeta again. Ladies and gentlemen, it's indeed a pleasure to be here today, and I'd like to thank the IFS chapter Vidarbha Society for inviting me today for this wonderful webinar. Today, the topic for me is, of course, poor ovarian responders, which continues to remain one of the greatest challenges that we face in any IVF clinic. And why is this so? And this is because you would agree with me that almost 50 to 60% of our patients fall in the category of either Poseidon 1, 2, 3, or 4. And of course, if we look at nature and how there is a decline in the follicular count over years, you can see that when a female fetus is at 20 weeks of gestation, there are approximately 1 million viable follicles which remain at birth. And at the time of menarche, women have about 300 to 400,000 follicles, and these are recruited cyclically until menopause. And it's an inescapable fact that by the age of 30, a female has lost almost 88% of her egg reserve. Of course, we all know the importance of estimating AMH, but remember that of the known factors that cause a reduction in AMH are smoking and low vitamin D levels. So these two must be corrected at the earliest. And also remember, many a times I see AMH is done, say after a couple of months of a birth control pill or while she is on a GnRH agonist, in which case you get a falsely low AMH level. So remember that you should do an AMH level when there has been 1 month of absolutely no medications prior to doing the AMH test. Now, how do we categorize response and how do we say that a patient is likely to be a poor responder? So obviously we take into account age, the BMI, her AMH and AFC. These are the common parameters which are used to diagnose a poor responder. You have to look at a previous response to ovarian stimulation and whether she has any associated endometriosis or PCOS. And then we can categorize the poor responders into 4 groups. To keep it simple and not to complicate matters too much, you have Poseidon 1 and 2, which is young and old patients who come to you with a normal ovarian reserve. So remember, these patients came to you with a normal AFC, normal AMH. You gave them a dose of FSH that you thought will give you an optimal retrieval of oocytes, but yet they don't respond optimally. So you have group 1A, which is 4 or less oocytes are retrieved, and group 1B, where 4 to 9 oocytes are retrieved. And then you have the young and old patients who come to you with a reduced ovarian reserve. So they come to you with a low AMH, they come to you with a low AFC. You are fully prepared that they are going to be poor responders. So you are well warned that they will need 2 to 3 months of some kind of pre-treatment before you rush into an IVF cycle. So together, the unexpected, that is Poseidon 1 and 2, where you are caught unaware during the in between while the cycle stimulation is going on, and the expected groups of Poseidon 3 and 4, where you are well prepared and you know exactly how to go about treating them. To understand the management and the best practice points for these patients, you need to be very conscious of oocyte numbers. You need to take every oocyte that you get very seriously. And why is this so? You can see here that to produce one top quality embryo, you need at least 3 metaphase 2 oocytes. So it's very important to remember this ratio, that if you get 10 metaphase 2 oocytes, you might end up with 3, and if you're lucky, 4 top quality embryos for this patient. Also, with increasing age, you need more and more oocytes to get a euploid embryo. For example, under 38, you may need 8 or 9 oocytes. 38 to 40, you may need 14 oocytes. At 41, 42, you may need almost 32 oocytes to get that one single euploid embryo, which will finally give you a take-home live birth. So why does every extra oocyte count, and why should all your management be aimed at getting a higher number of oocytes in these poor responders? And very good study by Bosdag in 2017 clearly shows that with every extra oocyte that you get, there is a significant increase in the live birth rate per cycle. So with one oocyte, if you expect just a 4% live birth rate, with 4 oocytes, it goes up to 16%. And with 5 oocytes, you can expect a good pregnancy and live birth rate of as high as 22% per started cycle. So what are the important points when we consider managing Poseidons 1 and 2? Now remember, there are 4 important reasons for Poseidon 1 and 2. Number 1, low gonadotropin starting dose. This is the number 1 culprit. We still see a lot of clinicians beginning stimulation with 112.5 or 150 or 187.5 for a thin lean PCOS, thinking that she will hyperstimulate. But today we have the antagonist protocols, we have the agonist trigger, we have the freeze-all. So there is no need to worry about these patients. There is no need to underdose a normal responder or a high responder, because we are no longer worried about hyperstimulation. So please do not begin with low doses of gonadotropins, because you will create an iatrogenic Poseidon 1 or 2. Number 2, we know 10 to 15% of poor responders will be carriers of genetic polymorphisms. And here we need to either start with a higher dose of FSH, or what we personally feel is better is to add LH right from the beginning of stimulation, so as to keep your FSH doses within control and not unnecessarily increase the cost of the cycle. Number 3, and the commonest mistake which is made, is asynchronous follicular development. About a decade ago, all of us switched to the antagonist protocols for all patients with a view to reducing OHSS, forgetting that poor responders are not going to have OHSS. And with the antagonist protocol, it's very common to see asynchronous follicular development. So one follicle reaches dominance. On day 7, you see a follicle of 15 mm, and the other follicles are lagging behind at 10 to 12 mm, because you began stimulation on late day 2 or early day 3, or sometimes even late day 3. And that is why the dominant follicle has already been selected. The selection usually occurs in the late luteal phase of the previous cycle, and that follicle shoots ahead, giving you an asynchronous cohort. And in the end, you have 6 follicles and you just get 1 or 2 metaphase 2 oocytes. And finally, the trigger. It is important to understand that for a poor responder, you cannot just give your simple HCG trigger. You need to give something which is better and more effective to ensure a complete conversion and maturation of the oocytes and give you the perfect yield of metaphase 2 oocytes. So remember, your minimum starting dose across all spectrums of patients, whether it's a poor responder, a normal responder, a high responder, should be 225 IU. And as per BMI and age, you could even start with 300 and even 450. Say for a 40-year-old who is obese with a low AMH of 1.2, 450 would be your starting dose of gonadotropins for this patient. So please do not underdose. And we have so many studies clearly showing that when you use 200 versus 100, you have a significantly higher number of oocytes. If you compare 225 and 150, again, you have significantly higher number of oocytes just by adding that 75 extra IU as a starting dose for that patient. What about dose adjustments? Previously we thought that if you start stepping up doses on day 7 or day 8, you will not recruit more follicles. And this may be true in the antagonist cycle, but I'll show you shortly how it does make a difference in agonist cycles. So suppose in the first cycle, you gave her 225 and she just gave you, say, 5 oocytes. Subsequent cycle, you should give her 300 or 375 or even 450, so that you get a significant increase in the number of oocytes. And you can see here, when you increase just by 225, say from 225, you go up to 300, means just step up the dose in the next cycle by 75, you have a significant increase. At least 4 or 5 extra oocytes will be recovered in the subsequent IVF cycle. So we know that dose adjustments are more frequent in patients receiving an agonist rather than an antagonist. And it is fair to step up the doses. If on day 5 or day 6 of stimulation, you see just 5 or 6 follicles, you can increase the dose by 75 or 150 IU. And in patients with poor ovarian response in an agonist protocol, if you increase the FSH dose during stimulation, you will increase the number of oocytes retrieved and reduce the risk of cycle cancellation due to inadequate follicles. Again, to emphasize a bit more on the importance of follicular synchrony, where pre-treatment becomes so important. So if a patient walks in on day 2 or day 3, don't just start the gonadotropin fearing that the patient may not come back after a month to you. Spend that month giving her antioxidants or supplements or whatever else you believe in, or maybe a testosterone gel for 21 days, and make sure that she begins on day 2. And also make sure that she takes some form of pre-treatment in this month, so as to give you a perfectly synchronous cohort. And what are the best ways to do pre-treatment? Number 1, luteal estradiol valerate. Very simple to use. Just give 2 milligram BID from day 25 of the luteal phase. You can continue it during menses. The beauty of 2 milligram BID is that the dose is not adequate to stop menstruation from happening. So menses will occur at its expected time and in the proper manner. You can then continue the estradiol valerate. Say she bleeds on a Monday and you do not want to start stimulation till Friday because you want to avoid a weekend egg retrieval. You just continue the estradiol valerate till Thursday, then begin FSH from Friday, and you can then expect a beautifully synchronous cohort. The bleeding will stop by Tuesday or Wednesday because of the estradiol valerate. The endometrium starts proliferating, but it will suppress the selection of the dominant follicle. So follicular dominance will not occur when you use luteal estradiol valerate as pre-treatment before beginning your stimulation. The second easy way to do it is to use norethisterone twice a day from day 20 of cycle, minimum 7, maximum 15 days. Normally, we ask the patient to stop it on a Sunday. Call her in on Friday morning to begin your stimulation. The 5-day washout period is required, just like you need it with an OC pill use, and then begin stimulation again. The dominant follicle will not have been recruited and you will get a synchronous cohort. OC pills, I am not too much in favor of OC pills because very often for poor responders, we need to use a dual trigger, which means I give agonist and HCG. And for the agonist trigger to work well, I need a good stock of endogenous LH. Now, if I give prolonged OC pills beyond 10 days, there will be suppression of endogenous LH, and then the agonist trigger will not be very effective in the dual trigger combination. The easiest to do, especially in clinics like ours, which are almost 365-day clinics, we don't need to schedule too much. We don't do batches. We have probably a daily program of IVF. If at all I want to avoid a weekend for a conference or something, all I do is give them the antagonist. Like say Monday morning, a patient comes on day 2. I give the antagonist day 2, 3, and 4. That is Monday, Tuesday, Wednesday. From Thursday, I will begin the FSH or HMG stimulation. And then I will add back the antagonist when the lead follicle is 13 or 14 millimeters in mean diameter, as you normally do with the conventional antagonist protocol, and go on with stimulation. And does this help? Beautiful study by Blockhill more than a decade ago clearly showed that when you use the antagonist for 3 days, you have an increase in the number of oocytes from 10 to almost 14. And this is very significant. If instead of 4, you get even 6 or 7 oocytes, you have done a great benefit to that patient and improved her take-home live birth rate. But the best, compared to all these 4 methods of achieving synchrony, personally, I am still totally in favor of the long agonist protocol. A lot of you who used to practice IVF, say more than 20 years ago, would agree that when we had only the long agonist protocol at our disposal, we never even knew what follicular asynchrony means. Her follicles always used to be of the same size, and this was because you had total control on the cycle. With the agonist, you would suppress everything. There would be no follicular selection or dominance. And when you started FSH or HMG, you had a recruitment of all the follicles at the same time. So on day 6 or day 7, all of them would be a beautiful 14 or 15 millimeters with just a difference of 1 or 2 millimeters between the leading and the next one. And that is why the agonist protocol should be your protocol of first choice for poor responders. And it is time to switch to this, because although I have been saying this for more than a decade now, that continue using the long protocol for poor responders, there was adversities that, oh, you are already suppressing an already suppressed pituitary axis even more when you use the agonist, and how will you get a good response? The trick is not to begin with pure FSH alone, but to add LH right from the beginning when you begin gonadotropins in a long agonist protocol. And what are the reasons and what are the studies available for this? One, first, it has a direct impact on oocyte and embryo quality. You can see here when you use the agonist, oocytes with cytoplasmic abnormalities are lower at 50% as compared to 62%. Significantly higher number of follicles and higher number of oocytes. The number of zygotes with normal pronuclear morphology again are higher with the agonist protocol, and therefore you get a higher clinical pregnancy rate up from 28 to almost 38% as shown by ECOS in 2009. And why does this happen? Because you maintain low LH and progesterone levels throughout the stimulation phase, which gives you a higher yield of top quality embryos with a better implantation potential. Synchronized follicular development is the #1 advantage. It makes sure that you get maximum recovery of metaphase 2 oocytes. And because you get a higher number of oocytes and embryos, you have a higher cumulative live birth rate because you have more embryos for freezing. And this was another study of 600 patients in each arm, again comparing the antagonist and agonist. And you can see with the long agonist, higher number of oocytes, more number of embryos, clinical pregnancy rate up from 32 to almost 58%, live birth rate up from 25 to almost 46%. And this is just one among several recent studies which have come in. But besides literature, it's always best to try it out yourself. And what we thought is, instead of taking 600 random patients in 2 arms, why not compare the agonist and the antagonist in the same patient? So we took a age group 27 to 41, all potential poor responders with low AMH. So these were all our Poseidons 3 and 4. And we did, in consequence, we did first antagonist cycle, conventional, and then the second cycle would be an agonist cycle with HMG or a combination of FSH LH. And we found that with the agonist, you had clearly higher number of oocytes as expected. But the main advantage was you had almost a doubling of the percentage of top quality embryos. So from 17.5%, you go up to 30%. And even grade 2 and grade 3 bad quality, poor quality embryos were down from 65% to just 38% when you use the long agonist protocol. What other factors do we need to take into consideration for Poseidon 1 and 2? And the next is, of course, the presence of genetic polymorphisms. We know that patients who are homozygous for serine require more gonadotropin and often are hyporesponders and take a very long time to stimulate. And you have patients with a variant of the beta subunit of the LH gene who also need higher doses of stimulation and probably a high dose of LH right from the beginning of stimulation. So if you were to use a high starting dose for all patients, maybe you would avoid this group of Poseidon 1 and 2, which is because of polymorphisms, by having rectified a lot of their issues right from the beginning, rather than then trying to step up on day 7 or day 8. And remember that LH supplementation is very important. Whenever you have a documented polymorphism, or if she has been a slow or a hyporesponder, and hyporesponder means that the follicles remain at 12, 13 mm for 5-6 days without any increase, despite you pumping in a lot of FSH. These are the patients who need a slight increase in FSH dose, but more importantly, you need to add 150, sometimes even 225 of LH to these patients to make their follicles start growing and counter the effect of the polymorphisms. What about Poseidon 3 and 4? Of course, these are the categories which we are pre-warned. They have come to us with low AMH and low AFC, and you now have to manage them with your IVF program. Now, very often I find the minute you see a low AMH, you say, oh, you don't have even a month or a week to waste. Immediately you should start stimulation, and in the bargain, you miss out giving her adequate pre-treatment. Remember, there are now studies to show that in such patients, if you delay treatment even by 180 days, that is almost say 6 months, you do not cause any further deterioration generally, and the outcomes are the same. So please take your 2 to 3 months to treat them with your coenzyme Q, your DHEA, or whatever else you believe in before you jump into IVF stimulation, so that you get the best outcome for this patient. And a delay of 2 to 3 months is not really going to cause a significant change in the outcome. Rather, you will have a better outcome because of all the pre-treatment that has been given. Again, to highlight the same point, a study in 2018 comparing the long agonist versus the antagonist protocol for various aged patients with poor ovarian reserve. And look at this. Once again, Poseidon 3, that is young patients under 35 with a low AMH or low AFC, live birth rate per transfer 30.8% with the agonist, just 16.7% with conventional antagonist. In this study, they did not find too much of a difference with Poseidon 4, where both agonist and antagonist performed equally. And so also Poseidon 4 above the age of 40, there was not much difference, and the pregnancy and live birth rates remained around 5% per started cycle. But all of you would agree that our biggest problem is Poseidon 3. We have so many patients under the age of 35 who have low AMH and low AFC, and here the agonist long protocol should be your first protocol of choice for these patients. And of course, this agonist is better than the antagonist because you have lower cycle cancellation rates, higher implantation rates, and therefore higher live birth rates. Does the agonist even have an effect on endometrial receptivity? And this is something we never considered as a possible reason for better pregnancy rates. Besides getting more oocytes, more top quality embryos, remember that studies have shown that patients using the antagonist protocol have a thinner endometrium, lower pregnancy rates, significantly lower HOXA10 expression in the endometrial stroma cells, and all of these impair endometrial receptivity, especially with fresh embryo transfer in an antagonist cycle for a poor responder. So not only does the agonist have direct effect on the oocytes, on the quality of zygotes, on the quality of embryos, but also gives you better endometrial receptivity, and therefore the huge increase in live birth rates once the cycle is completed. How high should you go with FSH dosing? Now here it's important to remember that you can't flog a dead horse back to life. The same, if the ovary doesn't have follicles, you cannot generate new follicles. So a lot of studies have shown us that 300 should generally be your maximum dose, especially for Poseidon 4, and you can go up to 450 sometimes. But as this study shows, whether you give 300 or 450 or 600, the outcome is generally the same. Your live birth rate will be the same. So there's no point pumping the ovaries with more gonadotropin. Sometimes very high doses of FSH can do more harm than any benefit to the patient. So which are the patients who actually benefit from a very high gonadotropin dose? Remember, again, when women are older than 30, they will benefit if you give 300 instead of 225 or 450 instead of 300, because you will get 46.5% will benefit as compared to 34%. Also, if the AFC is very low, between 1 and 3, then they will benefit from an increased FSH dose. So women who are aged more than 30 and have very low AMH and AFC are likely to benefit from an increased dosing of FSH by giving you more oocytes and therefore a higher cumulative live birth rate. What do we know about LH supplementation? Now we know that addition of LH is mandatory in all poor responders. You will have increased FSH receptor expression, improved follicular recruitment, and a reduced rate of granulosa cells apoptosis. So which category is mandatory to add LH? Number one, all elderly women, that is above the age of 35, you must give some form of LH from day one of stimulation. Then all hypo responders. Suppose in the past cycle, she has had a very slow response and the follicular phase went on for 15 to 20 days. Please add LH right from day one in her next cycle. All patients with hypo, you have to begin stimulation with a combination of FSH-LH. And remember that the starting dose of HMG for a patient with hypo should be 300. Remember that if you give 150 of HMG, she is not going to respond. 225, she is probably also not going to respond. She has absolutely no endogenous FSH-LH. So even if she is young and she's thin, she doesn't have any endogenous FSH-LH, and you have to start with 300 if you have to get her good response for her. Just in the past 3 months, we've had 2 pregnancies in hypo, and both had the same story. They had been elsewhere. They had been started on 150, then stepped up to 225, then told there is no response and you need to go for egg donation. And the minute we started with 300, within 7 days, they have a lot of follicles. And that is where clinicians often get scared that they will have OHSS. You don't need to give them the antagonist because they will never have a premature LH surge, and you cannot use the agonist trigger. So you have to use a HCG trigger. On an average, if the patient is young, she will generally give you 20 to 30 oocytes, which you can aspirate, fertilize, and freeze all. Just give her cabergoline and letrozole for 5 days after egg retrieval, and guaranteed she will not have any hyperstimulation and she will be absolutely fine within 2 or 3 days. But if you start with lower doses, she is not going to respond. So this works beautifully. Of course, you can't give them rec FSH. You have to use with conventional, start with conventional urinary HMG in a dose of 300 IU right from the beginning. And of course, for all the poor responders, there are enough studies now to show that there is an increase in the pregnancy rates if you add LH right from the beginning. So there's no more debate to add or not to add, which we kept hearing for so many years. It is now confirmed that you have to add. What should be your source of LH? Now, you know, native LH has a very short half-life. And you also have preparations which have HCG-driven LH activity, and HCG has a long half-life. So therefore, it tends to accumulate and often gives you a better response. So what we like to do is use HCG-driven LH activity right from the beginning, along with FSH for poor responders. And you can see when you use native LH, there is no accumulation. So your live birth rates are pretty much steady at 10%. But if you use HCG-driven, there is an accumulation of HCG. And the higher the level of HCG on day 6, the higher will be your final live birth rate. So this is how you could exploit various different preparations. Try to source a preparation which has HCG-driven LH activity to give you a better outcome. The final important point, of course, in Poseidon's 1 and 2, and of sometimes even in 3 and 4, is the use of the ideal trigger, because many a times you have 20 follicles and you end up with just 10 oocytes. Sometimes you have 10 oocytes and get just 2 metaphase 2s. Sometimes you have 2 metaphase 2s and don't get any top quality embryo. So these kind of performance is usually related to the final trigger which is given, and to the fact that there should be no prolonged OC pill pre-treatment before the cycle. So why is dual trigger important? Remember that in a normal menstrual cycle, when you have a mid-cycle LH peak, you also have an FSH surge. Now, when you give HCG, you are only simulating the LH peak and you have done nothing to simulate an FSH surge. But when you give the agonist trigger, it induces a very physiological peak because it causes release both FSH and LH, and therefore it mimics the normal physiological menstrual cycle much better than if you were to use HCG alone. And that is why the final outcomes are better. And you can see here when you use a dual trigger, HCG 6500 with 0.2 milligrams of triptorelin, you increase your clinical pregnancy rate from 20 to almost 33%. So there is an improvement in all the outcomes, especially women with diminished ovarian reserve, as this study in 2019 showed. And this study also did a little more fine tuning to get more metaphase 2s. So you give the agonist trigger at 40 hours and you give the HCG trigger 34 hours prior to egg retrieval, and therefore ensure a better number and a higher number of top quality embryos, as this particular study showed. Is the agonist trigger better than HCG? So there is even a suggestion that if you are planning to do a freeze-all anyway and not do a fresh transfer for this patient for whatever reasons of endometrial thickness or so on, then maybe you could use just the agonist trigger, because studies have shown that agonist trigger will give you higher number of oocytes, higher number of blastocysts, and you can see the blue dotted line, higher cumulative live birth rates with embryos generated from the agonist trigger as compared to embryos generated from an HCG trigger. So sometimes maybe the agonist trigger alone could be your trigger of first choice, but the dual trigger generally is recommended for most of your poor responder categories. Another interesting thing, please do not perform dual stimulation as you have been used to doing it, because we have been doing it not exactly in the correct manner. And how did it all start? We thought there are 2 or 3 waves of follicular recruitment in a menstrual cycle, and that conventional stimulation does not take advantage of the entire follicular cohort over a 28 to 30-day cycle. So you're wasting follicles of the second and third waves. And therefore, we started dual stimulation, where we, of course, would give FSH from day 2 or 3, then add the antagonist, then use the agonist trigger, do an egg retrieval. She would menstruate in 3 or 4 days and then begin second stimulation, and then again do an HCG trigger and do a retrieval. Now, this seemed to be okay, and we actually had studies showing that luteal phase stimulation results in more oocytes than follicular phase stimulation. Then we had studies that luteal phase derived oocytes are as competent as follicular phase derived oocytes. You can see blastulation rates were better actually with luteal phase stimulated ovaries. Then we had, okay, clinical pregnancy rates in fact are better with luteal phase generated embryos at 47% as against 26% with follicular phase generated embryos. There was no difference in the euploidy rates when PGT was done for the follicular phase and luteal phase generated embryos. And obstetric and perinatal outcomes were also comparable. You can see a live birth rate per single embryo transfer 53% using follicular phase derived euploid single blastocysts, and 48% with luteal phase derived euploid single blastocyst transfer. So we had so many papers in a rush, and all of us blindly got into using dual stimulation to try and improve our outcomes. But now there is a major twist in the tail, and it always goes back to your basics and your basic knowledge of the menstrual cycle. And what did we do wrong? When we use an agonist trigger in the follicular phase stimulation, it has a very, very short life. There is abrupt luteolysis, and the patient menstruates within 3 or 4 days. If you were to do an estimation of estrogen progesterone on the second day of that bleeding, the levels are the same as the follicular phase and not high progesterone like a luteal phase. So how were we even calling it a luteal phase stimulation? So what we were actually doing all this while, and practically the whole world stands guilty at this, we were doing 2 follicular phase stimulations back to back and calling it a dual stimulation. At the same time, because we were doing the conventional dual stimulation, we could not do fresh embryo transfers, because you are doing a luteal phase stimulation and doing a retrieval. The endometrial receptivity obviously would not be the best. So we were following the freeze-all policy. And now, there is a lot of talk of not doing freeze-all for all on a routine basis because of genuine concerns of macrosomic fetuses and a double incidence of PIH in mothers who undergo HRT FET cycle. And the large baby syndrome and all these are now becoming major concerns for us with FET cycles. So the twist in the tail is that the correct way to do dual stimulation would now be that you do your first stimulation in the actual luteal phase. So instead of doing FPS first, you do LPS first. As soon as you document ovulation around day 14, say 2 or 3 days later, day 17 to day 21, you begin your stimulation, add your antagonist, give the agonist trigger, do your retrieval. Then within 3 days or so, she will menstruate. Now you do your conventional follicular phase stimulation, add the antagonist, this time give an HCG trigger, give luteal phase support with progesterone, and do a fresh embryo transfer so that you have corpora lutea in the first trimester of pregnancy, and you reduce the incidence of PIH and remove the risk of macrosomic fetuses. Of course, for the transfer, you can use embryos either generated fresh in the follicular phase or the ones frozen in the luteal phase stimulation, depending whichever were of better quality for embryo transfer. So this is the twist we have for dual stimulation. What about freeze-all? Many a times we hear that, oh, she has just 2 good quality embryos, let me freeze and let me do a second round. Why do you want to freeze? Why can't you do a fresh embryo transfer for this patient? And remember that there are a lot of studies now showing that when you have poor responders, freeze all or fresh ET will give you the same clinical pregnancy rate. So we no longer have poor response as an indication for freeze all. So anything less than 10 oocytes or 13 oocytes, progesterone on the day of HCG between 0.5 and 1.5, good triple line endometrium between 8 and 12 millimeters. So all your parameters are satisfied. You can easily do a fresh transfer for these patients and expect the same good clinical pregnancy rate as you would expect with a freeze-all for these patients. So you can see Roche study from 2017, 1 to 3 oocytes, fresh and frozen, same. 4 to 9 oocytes, fresh and frozen, same outcomes. 10 to 15 oocytes is a gray area where maybe freeze-all is better than doing a fresh. And more than 15, of course, we know in high responders, freeze-all is better because supraphysiologic levels of estradiol progesterone when there are more than 12 or 13 oocytes are not conducive to good endometrial receptivity. Very important part, especially for Poseidon 3 and 4, is the use of adjuvants. And remember that ovarian aging involves damage to a lot of factors in the oocyte. So you not only have DNA damage and genetic mutations, you have problems with meiotic recombinations, telomeres, mitochondrial dysfunction is one of the biggest problems with aging of oocytes. Then, of course, you have your oxidative stress and so on. What is the evidence available to us as to what we should be using? And this is one of the largest meta-analysis which was done and clearly shows that only 3 adjuvants, DHEA, growth hormone, and coenzyme Q, actually have evidence that they work and they give you better outcomes in Poseidon's 3 and 4. So androgens, of course, we know are important at every stage, whether it is primordial, primary, preantral, antral, or periovulatory follicles. At every stage, good androgen levels are important to give you good quality oocytes. And we had initial papers in 2017 and 18 that transdermal testosterone does improve most of the parameters when you consider oocyte numbers, number of embryos, and so on. Then there was this large meta-analysis in 2022, which said that, of course, there was no benefit with DHEA when compared to placebo. But this is again highly debatable because you have an equal number of papers showing that DHEA probably works. And it said that testosterone pre-treatment yielded a higher number of eggs, higher clinical pregnancy rate, and higher live birth rate. So to my mind and my experience, I feel both work equally well. The only difference is that DHEA you have to give for 60 to 90 days. Testosterone you can use just for 21 days to get the desired effect and a better response. What about growth hormone? There's a lot of rejuvenation for growth hormone. And the confusion was because if you look at literature, too many different regimens to begin in the luteal phase, follicular phase, give alternate day, give daily day, give 4 IU, give 8 IU, give 2 IU, give until day of HCG, and so on. So we didn't have any standardization and any proper RCTs to tell us whether it really helps. But it's a known fact as per recent studies that growth hormone will help to increase the number of oocytes, the optimal embryos, embryo implantation, also improves endometrial thickness on the day of HCG and therefore gives you higher pregnancy rates. So you can see here this large study from 2023 clearly showing improvement in clinical pregnancy rate, number of oocytes, fertilization rate, endometrial thickness, and there was a reduction in the amount of gonadotropin required for their stimulation. But yes, we still need, most of us try to use 4 IU or 8 IU from day 2 until day of HCG, but we need more standardization and further research to come out with the exact and the best protocol so as to make it cost effective and at the same time give us the benefit of using growth hormone. What about improving mitochondrial integrity? Because the biggest problem in Poseidon 3 and 4, especially 4 with aging, is an effect on the mitochondrial integrity and mitochondrial damage. And this is where coenzyme Q and its active ingredient ubiquinol plays a very important role. So you can see this beautiful study here. The first ovary is a young mouse ovary. The second is an old atrophic mouse ovary. And the third is this same old ovary after 15 weeks of coenzyme Q pre-treatment. And you can see the amount of regeneration of primordial follicles that you have in these patients. So the use of coenzyme Q 200 milligrams thrice daily, that is 600 milligrams for 60 days preceding the cycle in Poseidon's 3 and 4 will give you a higher number of oocytes and better outcomes. We then have resveratrol. Of course, it's very popular. We know it's extracted from the skin of red grapes, has a lot of anti-aging, antioxidant, anti-inflammatory effects. The main advantage being it improves mitochondrial function. It also has a lot of anti-apoptotic effects, and it will give you a good, better response, better number of oocytes, better quality of mitochondria in those oocytes. But of course, at the same time, very high doses can lead to embryo apoptosis. So you have to moderate the dose generally to around 40 milligrams a day. And a synergistic combination of ubiquinol with resveratrol gives better performance than just using one or the other. We recently also have evidence that pterostilbene also is a good agent to give these patients, because resveratrol activates a broad array of disease-preventing genes, beneficial effect taking place more upstream. Pterostilbene directly activates genes downstream from the sites of resveratrol's action. So acting together, they produce a lot of potent longevity-producing effects. Melatonin also is supposed to help these patients because it efficiently decreases oxidative stress levels, improves oocyte quality, especially in the elderly age group. And this was the another large meta-analysis in 2023 showing coenzyme Q is the best performance-wise. There is a 2.22 times higher clinical pregnancy rate than without CoQ. DHEA next at 1.92 means almost double. And then you have, of course, growth hormone at 1.56. And this shows the tremendous improvement that you have in your responses with the use of these various adjuvants as pre-treatment. What about letrozole? Letrozole, along with the gonadotropin in poor responders, this one large analysis is there of 16 RCTs, showed that the live birth rate increased by about 7%. And in a poor responder, even if you have an increase by 5%, it's reasonably good adjuvant to use in these patients. Some facts for endometriosis, because we keep having this perception that endometriosis doesn't have good eggs and so on. Remember that although we feel that yes, the response may not be good if she's had previous surgery, egg retrieval may be difficult because of the presence of large endometriomas. Fertilization, we always thought ICSI is believed to be better and don't do conventional IVF. And implantation window also will be affected. Endometrium may not be the best and so on. But the current status as of 2023, endometriosis has a negligible impact on ovarian response. Slight reduction can be observed if endometriomas are larger than 4 centimeters. Oocyte quality is not hampered. Fertilization rates are similar. So the decision to do IVF or ICSI should be based on sperm and other parameters and not because it is endometriosis. There is no increase in aneuploidy rate over and above the age-related risk. Endometrial receptivity is either unaffected or very slightly impacted. And therefore, remember that endometriosis, there is no need to be scared for it. If her AMH is reasonably okay or even a bit on the lower side, you may get fewer number of oocytes, but you will not get lower live birth rates per embryo transfer. We now know that a lot of patients of Poseidon 3 and 4 may be associated, also have an increased spontaneous miscarriage risk. And this is because they compared these patients and they found that there is a 1.5 times higher risk of miscarriage when AMH is less than 1.1, 1.62 times higher for AFC less than 5, and 1.4 times higher if FSH is more than 10. So remember that 158 of these patients shared genetic risk loci were found that affect both miscarriage and menopause in these patients. So patients with poor ovarian reserve, especially Poseidon 4, may have a genetic link to getting early menopause as well as to having recurrent miscarriages. Laboratory essentials, of course, Dr. Varsha will I think cover most of these essentials, but one or two things which I feel strongly about. One, that there is no proven benefit of doing ICSI over conventional IVF just because you have a fewer number of oocytes. And you can see the number of publications we have in favor of this fact. And you can see here whether you have 1 oocyte, 3 oocytes, 4 oocytes, outcomes with IVF and ICSI are the same. There is no advantage of doing ICSI even if you have just 1 oocyte retrieved. And why is it this important? Why do I keep saying don't do unnecessary ICSI? Because a lot of you might have been online for this wonderful webinar from John Hopkins by Valerie Baker just in June last year, 2023, where they have followed up 2 lakh infants born through IVF and ICSI procedures. And they found that when you do ICSI, in the absence of a male factor, you are increasing the risk of anomalies. So you can see here blastogenesis becomes 1.5 as against 1 in natural born babies. So what does this mean? This means that if your blastogenetic anomalies were at 2 in 100 for ICSI babies, you are now making it 3 in 100 by doing unnecessary ICSI in the absence of a male factor. So remember, try to avoid ICSI when not indicated. So when a poor responder gives you 2 oocytes, it doesn't mean you need to do ICSI, especially when you don't have male factor, you are unnecessarily increasing the risk of anomalies. And also, because we are talking about this webinar, they also said that twin pregnancies are not an ideal outcome, and there is a very high risk of anomalies with 2 things. One is in a twin pregnancy and one is unindicated ICSI. So remember, you have to counsel your patients that if I do 2 cycles with just 1 embryo transfer, your probability of live birth over those 2 months is 64%. Risk of multiple pregnancy is almost 0. But if you do 1 cycle with DET, that is double embryo transfer, you get a good live birth rate of 55%, but you have almost 40% chance of a twin pregnancy. So we need now to pledge in 2024 that we will just transfer 1 embryo for all good prognosis patients to eliminate this. And a very good article, whenever you have an elderly patient, a Poseidon 4, elderly woman with a low ovarian reserve, please do oocyte activation for all these patients so that you get the best recovery of top quality embryos. Very easy to do. You just have to incubate the solution for 4 hours. Once you have injected with ICSI, you just put the oocytes for 15 minutes into the calcium ionophore medium for oocyte activation, then wash them and transfer them to culture medium, and you get a much higher cleavage rate. And more importantly, you have a 3-fold increase in the possibility of getting more than 1 top quality embryo, especially when you use it for Poseidon 4 patients, especially those older than say 38 or 40 years of age. Mitochondrial enrichment, of course, I think Dr. Manju Jila will cover, so I'm not going there. What do you counsel for success rates? Cumulative delivery rate per aspiration in Poseidon patients. This is the first largest study that we have this perception that, oh, Poseidon 1, 2, 3, 4 don't do too well. But what is the actual pregnancy rate? And as expected, the young ones under 35, that is Poseidon 1 and Poseidon 3, good reserve, poor reserve, reasonably good pregnancy rates. So no need to be disheartened if she has 4 oocytes, 5 oocytes, she's less than 35, she will still have a good 40% chance of a take-home baby. And so also will the poor ovarian reserve Poseidon 3 group have almost a 30% chance. Of course, the age group above 35, not too bad, but not as good as the younger patients as expected. Poseidon 2 at around 20% and Poseidon 4 does the worst at around 17%. So of course, age related, you will have differences in the final cumulative delivery rate per aspiration. And this is something you need to counsel your patients before you begin. Future, of course, we'll be hearing soon about PRP and how it works. And mainly, we just have one large paper here from on 510 women, but it was all done transvaginally, which I find a little difficult. If you have to actually inject on both the sides of the ovary, it's not really possible vaginally. So I still prefer the laparoscopic route for the occasional patient where I use PRP. But this study showed fantastic results. Number of mature oocytes increased, blastocysts increased. And in the young category, again, the live birth rate was almost 34% with the use of intraovarian PRP. We also have ovarian fragmentation, OFA, where initially it was done with P10 inhibitors, means you needed 2 laparoscopy surgeries. They would take a ovarian tissue biopsy, incubate it with P10 inhibitors for 2 days, then again do a second laparoscopy to implant the ovarian tissue back. But then it was found that P10 inhibitors may be carcinogenic. So now we have a new method where you just do a lap retrieval of a small cortical biopsy, fragment it into small pieces, make some subcortical pockets at the same sitting, and immediately fill up those pockets with the tissue fragments. And this is supposed to interrupt the pathway, the hippo pathway, which regulates the organs and cell proliferation and generation. So this is how it works. And this is just one study where it shows maybe a 13% clinical pregnancy rate and a 6.7% live birth rate per cycle. But of course, we need a lot more research there. What if all fails? Of course, you have for the poor responder, finally, the resort of your oocyte donation from one egg donor who is donating for the first time and the last time in their life to just one couple. And we will utilize 7 eggs to give the patient and the couple a complete family. Be very, very careful of the new laws when you do egg donation. Of course, today we are not discussing egg donation. And finally, prevention is always better than cure. So how do you eliminate this epidemic of poor responders, say 10 years from today? And that is where we need to educate all girls, especially those who are pursuing careers, deciding to postpone their marriage, not found the right partner, not financially stable, delayed childbearing at say 38, 40, that they must freeze their oocytes. And the best age for freezing oocytes is between 28 and 32 as per the latest American guidelines. And I've noticed that change, about 8 years ago when we started, we used to only get 38, 40 and 42-year-olds coming for egg freezing. Now, in the past year, we have 28, 29, 30, 32 as the commonest age group coming in. Also, we have found that it's very important. There's a lot of awareness now. 8 years ago, I used to do maybe 4 egg freezings in a full year, and now we almost do 4 per week. So that is the kind of awareness which has come up, especially in urban metropolitan cities. And we know that it's very important. It's a duty to educate the entire young generation that if you are planning to postpone your childbearing, please freeze your fertility, because the pelvic clock is not stopping for anyone's career, and it is not going to give you good outcomes at 35 plus. So finally, of course, a few ASHRAE guidelines to end as always. Agonists and antagonists equally recommended. 300 is recommended over 150. 300 over 150 not recommended for groups 3 and 4. Here I disagree a bit. I think Indian women need 300 in Poseidon's 3 and 4, and 150 is probably too inadequate. Modified natural cycle mild stimulation are not recommended. Adjuvant GA, growth hormone, DHA, aspirin in this ASHRAE guidelines, which is now 3 years old, was not recommended for low responders. And currently, of course, the evidence shows that at least DHEA, growth hormone, and coenzyme Q do work. Addition of LH is important. Dual stim at that time was not recommended, and benefits of luteal phase stimulation need more studies. So Poseidon's 1 and 2, pre-treatment, very important. Ensure correct starting dose of FSH. Add LH from the beginning if you have polymorphisms, and try to use as much of agonist protocols, even for normal responders with a AMH around say 2 to 2.5, rather than jumping for the modern antagonist protocol. Poseidon 3 and 4, again, agonist should be first choice. Dual stimulation if done in the correct manner. Embryo accumulation sometimes, if the patient wants to have 2 children and you feel okay, you should do 2 or 3 rounds of stimulation. Ovarian activation and OFA, and of course, oocyte donation as the final resort. So what do I do in practice? 60 days of pre-treatment, of course, for Poseidon 3 and 4. You can't do it for 1 and 2 because you are caught unaware and you didn't expect a 1 and 2. So coenzyme Q, resveratrol, ARG9, all these are our favorite supplements to be given for about 60 days before starting stimulation. We still use the testosterone gel rather than give DHEA for about 20 days pre-stimulation. Long agonist protocol directly starting with HMG 300 or 450 is the protocol of first choice. Short antagonist with pre-treatment, and of course the regular way of doing it with a dual trigger. Second choice, dual stimulation. Once we have results of the new study by Polizos and Annalisa Raka, I showed you the correct dual stimulation with the publication is expected very soon. Fresh transfer, if progesterone is normal, endometrium is a good triple line, and you have your 2 top quality embryos. If you don't get 2 top quality embryos, maybe you could do a 2nd or 3rd round, accumulate some embryos, and then do a good frozen embryo transfer. And finally, every day we have new IVF add-ons. This will help, that will help, do this, do that for poor responders. But please, even if you have patients who are willing to pay for all these expensive adjuvants, it is not always in their best interest, and it is our very, very serious duty to rigorously evaluate emerging therapies and interventions before directly applying it into routinely treating the poor responders. So thank you, ladies and gentlemen. Thank you once again, IFS chapter, Vidarbha Society, and all the organizers for this wonderful opportunity. And thanks to Corona Pharma also for putting together this webinar. Thank you so much.
It's amazing. Very
Dr.
nice.
Jatin, it was an amazing talk. And I think very beautifully you covered the pre-treatment, the different doses and types of gonadotropins, the protocol, especially emphasizing on the importance of the agonist protocol. Then you spoke about the triggers. You included even the adjuvants so beautifully. And your visual effects actually added to the beauty of your presentation. The amazing part is that all the recent, evidences were there in your presentations, where you also spoke about being ethical, one of the last slides. So I congratulate you for such a comprehensive and beautiful presentation.
Thank you.
And we have some questions. I think the questions would be on the other link. So
Hi,
if
Nitin.
Dr.
Nitin.
You can ask if you are having any questions.
Yes.
You can ask.
Hello, madam. Good evening. Good evening to all. Yeah, and Dr. Jatin, it is as usual a mesmerizing lecture.
Thank
And
you.
yeah, and these are, we know it's always a confusing and enigma for all of us. I just wanted to ask one question. Are you doing, what about the high LH on day 2 before the stimulation? Do you believe on it? And how, if it is there, how you would like to tackle it?
No, I don't really believe in it, and I've never estimated day 2 LH. So I go by my scan. If I see a total endometrial shedding, if I see quiet ovaries, no follicles, no cysts, and in poor responders, LH you would expect more in the PCO category. In poor responders is unlikely to be there. So normally we never estimate it and we directly begin stimulation. But pre-treatment is again important. So if you have given her estradiol or norethistérone, even if you had that occasional high LH, it is going to be suppressed because of the pre-treatment. So generally you don't need to worry about it.
Second thing.
In fact, I am encouraging adding LH from day 2 for all poor responders.
Yeah, that's the question I was going to come. Is there something called as LH ceiling effect? And when we add the LH, especially if you add the recombinant LH right from day 2, is it likely that it will have some ceiling effect and then further development of the follicle is hampered?
No, not really. So basically in antagonist protocol, try to maintain a ratio of say, you can use 300 of Rec FSH and 150 of Rec LH. So 2:1 is what is recommended. And now, of course, we have ready preparations of recombinant FSH LH combined by one international company. You are aware of that. And the fact that, we started doing luteal phase stimulation with high progesterone and high LH, that takes away all these theories of high LH, being bad for the oocyte quality. So when you do random start stimulation for cancer patients for oocyte preservation, you start anytime. The day she steps in, you start stimulating. So if LH doesn't affect those categories of patients, why should it affect our regular patients? So basically, there is a lot of rethinking about all this. LH, we are not giving it the same kind of importance we used to. And I think poor responders 150 from beginning, and even all normal responders, I add 75 LH for each and every patient, even a young normal responder, even a PCO patient. Because now we have the Megaset HR trial, which shows that LH in fact helps to reduce miscarriages in PCO patients if you give it right from the beginning. So that is my take on LH right now.
And regarding the pre-treatment, sometimes you feel even if there is a residual follicle of let's say 15 millimeter, 16 millimeter, so which pre-treatment will prefer? You like to go for norethindrone or you can go?
Yeah, so what I like to do is, that's a good question. First, I look at the endometrium. If the endometrium is completely shed and atrophic, 9 out of 10 or 99 out of 100, that cyst is non-functional. But still, if you are a little jittery, you just do the estradiol progesterone in the morning, right, on day 2. And if the estradiol comes back less than 50, progesterone is less than 0.5, it is a non-functional cyst. You just make a note of it and start your stimulation so you don't confuse it for a follicle. That's all you have to do. If the endometrial shedding is not complete, that means there is some hormonal activity coming from the cyst, or if your estradiol is more than 50 or progesterone is more than 0.5, then I give norethistérone just for 5 days. I don't give 1 month of OC pills because OC pills we just don't want to use because the next month will not be an optimal performance. So I will just give a norethistérone 5 days. So suppose I have seen her on a Monday to Friday, then I wait 5 days washout, and then I begin stimulation irrespective of whether the cyst is there or not. So that is usually more than adequate to take care of all these problems.
Okay. So, but then you do not, day 20, do you call your patient back before you start with the pre-treatment to them?
Day 20 means?
The day 20 of a previous cycle. When you start with on day 20, when you start with the
Or long agonist.
No, for even routine antagonist.
No, that we don't call them. Day 25, they have to start wherever they are. They directly come in during menses, and that is the time I will check.
You take the action on that. Okay.
Okay, so Dr.
No,
Jatin,
cysts are quite overhyped. This good you brought up the topic because this cyst thing is always, then they start giving them 2 months of overall G, overall L, and all that is just not required with all those patients. And the other thing is people don't do an immediate frozen transfer. In a PCO patient, you give an agonist trigger, you do a pickup, you freeze all the embryos. Then a lot of clinics give a 1 month break that, the ovaries are enlarged, you have to wait, let it all settle down, and then we'll do the frozen transfer. Again, there's no logic because when you use an agonist trigger, there is such instant abrupt, luteolysis. In 4 days, she menstruates. Cysts will take time to resolve, but they are totally non-functional. So you have to start the estrogen on day 2 and do within 20 days, do a transfer, even with those cysts being present. It makes no difference. And now there are 2 large studies showing that immediate frozen embryo transfer gives higher pregnancy rates than if you give a delay of 1 month. And this is because it's not only hormones coming from the cysts, but you have a lot of angiogenic factors which are good for the endometrium and the endometrium receptivity. So it's always better. And ever since 10-15 years, we started doing freezing. I used to always do immediate transfer, not knowing that other clinics are giving a 1 month break. And now we have studies showing that immediate transfer is more successful than giving a break.
But you have mentioned also the antagonist also, no? If suppose the cysts are there from 3
Yeah,
doses
and
like
day
that.
2, 3, 4, you can give that also. Yes.
Yes.
Any of those things work in just short term. You don't need to give 2 months of high dose OC pills.
Okay.
I think OC
Do
pills,
you
anyways, the message should be that OC pills should not be given anyways as a pre-treatment for the
For any
full
IV
21.
session.
Yeah,
you
because
get it
that may
absolutely right.
reduce the hypertrophy.
Okay.
So that is one thing. Dr. Jatin, I also had a question, a vice versa of the situation. Like if there is no cyst, nothing, and as a routine, if some center is getting a serum estradiol level done on day 2 or 3 before starting the antagonist protocol, do you use any cutoffs, or if the ovaries are quite okay, no cyst, they look to be silent, and still if the estradiol level comes out to be 100 or something, because we've seen in quite some patients, do you just ignore it or you do something about it?
So again, the trick is the scan. In your scan, you have to see a straight line for the endometrium. Means it has to be 2 mm or less. If you see that on day 2, you don't need to estimate any levels. If your estrogen is 100 plus, you will not see that straight line. You will see a little bit of endometrium still there, which will raise a suspicion about that, right? So again, in my practice in 30 years, and after AMH came, we started doing AMH. Before that, we never did any hormone estimations. Way back in 30 years ago, we used to do FSH on day 2 just to predict that is she going to be a poor responder, normal responder. And then directly it was beta HCG. And even today, I only do AMH and direct beta HCG. There is not a single hormone estimation done in between because I frankly really don't know what information it's going to give.
Progesterone on the day of HCG.
Yeah, that
So
is
you
if you are planning a fresh transfer.
Yeah.
So you also spoke about the increasing numbers of social egg freezing at your place. So do you have any, like how many M2s would you like to freeze?
So we counsel the patient that, the best thing is if you have 10 M2s of good quality frozen, your future chance of pregnancy with IVF would be around 65%. If you have 20 M2s frozen, you would reach 85 or 90%. Of course, the percentages will also be told as per their age-related statistics. So if she comes in at 40, I'm going to tell her your chance is 10% per cycle. If she comes in at 28, I'm going to tell her it's 60% per cycle. We also tell them that you are not infertile. So we can't compare your statistics to statistics of infertile patients, but obviously you are in a better zone. We also tell them that as of today, only 6% of girls in the world have actually used their frozen eggs. We estimate that 40 to 50% will get pregnant naturally because they don't have infertility issues. And this is just like a insurance policy of your car that if you have an accident, then it's useful. Otherwise, you may never use it. So all this is very important because they're spending a lot of money just to, because there's so much propaganda on egg freezing on every platform that now it's difficult for us to tell them don't freeze. Of course, we keep encouraging them because we know it's the way forward. We know that with oocyte donation and all these things becoming so difficult and with so much education, women don't accept egg donation as easily as used to do 20 years ago. So with all this in mind, egg freezing is very, very important and we need to encourage and to do it. But at the same time, they need to know all these statistics because they will spend on the procedure, they will spend on annual maintenance of the eggs. So they need to know at least this much, that what are the chances of pregnancy, what are the chances you will use it, and what are the chances that you may never use the eggs in the future. So all this we counsel them on the first sitting itself.
Okay, one more question regarding the egg freezing. If the patient comes at the age of 26 and her AMH level is somewhere around 1, and you have told that it is now we can do the egg freezing from 28 to 32. So or if the patient wants
No. That is ideal age. Like in the US, at US, who is going to do at 26? So these are US American guidelines. What I'm trying to say, the younger you do, the better it is. Now 26 with 1, obviously I will encourage you to do. Recently, I did one patient. She was 23-year-old. She's a budding actress. She's just 23. But nowadays I don't know why these all these laboratories in their annual checkups they include the AMH level, and that is creating a lot of panic, with these young girls. So she saw the AMH, it was 0.7. She came running at 23. And then we had to do an egg freezing and we got 12 eggs with a long protocol. So we said it's enough. You can freeze this much. But then 23 also is fine. 26 also is fine. Low AMH, maybe you should do it as soon as possible. You can't tell them, oh, you wait for 2, 3 years, 5 years because she doesn't want a baby in 2, 3 years. So she has to freeze her eggs. But the younger you do, the better it is. So 23 is perfect. 26 is perfect. And for Western women, where they don't even think of all this probably till 32, 33, they are told that 28 to 32 is your best age.
Okay.
I just wanted to confirm for the pre-treatment, we are just giving estrogen 2 milligram BD and we're not giving progesterone for the withdrawal. Patient will get bleeding even if she is on estrogen.
So this is for normal menstrual cycling patients, not for PCO patients, right? For normal cycling patients.
Yes.
So her menstruation date will not change by even 1 day. That is the beauty of 4 milligrams. So don't give 6 milligram. Otherwise, she will not bleed.
Okay.
You have to maintain just 2 milligram BD and she will bleed. Then you can continue for up to 9 days. You can prolong stimulation by 9 days. I told you Monday to Friday, but maximum you can take it to 9 days, which was written in the slide.
Yes, yes, yes.
And suppose you are given a pre-treatment, and in spite of that, on day 2, if you find there is some asynchronous growth, there is a not a ideal follicle size. So, will you like to continue in the same patient, or will you like to wait for her?
No, good question. So this is where the antagonist works the best. You just give antagonist for 3 days, day 2, 3, 4. When she comes in on day 5, that dominant follicle will have disappeared. And you will get a uniform cohort.
Uniform. Okay. Good.
Okay, good. So do we have any other questions? Dr. Neha, Dr. Swada, do we have questions from the other link for Dr. Jatin?
Ma'am, I cannot see any questions in the chat.
Corona people, any questions from the chat? From the other link?
Yes, ma'am, there is a question from Dr. Darshana. She is asking to Jatin Shah, sir, you don't estimate any hormones on day of trigger.
Yeah.
Only if I'm
Serum.
contemplating a fresh transfer, then I do serum progesterone. That's all. And importantly, I don't look only at the upper side. Even if it is below 0.5, I don't do a fresh transfer. So it has to be 0.5 to 1.5. If it is less than 0.5, then freeze-all is better because the adequate secretory changes would not have occurred.
Yeah. And Dr. Jatin, do you use any glutathione? Now there is a lot of things about glutathione.
I'm waiting for some publications. Like I said, we have an ethical responsibility not to jump into something. I know glutathione is very good for glowing skin and anti-aging and everything, but we still don't have enough publications for eggs. So everything comes with a bang and then goes away with a bang. So let's wait. Like dual stim was a classic example. Then even DHEA for 10 years, all of us used it. Left, right, center, without any real evidence. Although the trials kept fluctuating to and fro. Now again, they're saying it is useful. So everything you have to wait for trials. So there's a lot of I also read about nicotinamide, and while I was doing research, glutathione, all these things are there now.
Melatonin.
Tissue cryopreservation to delay menopause means at 28 you take a piece of ovary and freeze it, then reimplant at menopause so that another 10 years you keep menstruating. So all these things are futuristic things. We still don't know. But have you used glutathione since you asked me?
No, actually, I am doing Ovarian PRPs, and in that I have used glutathione for 1 or 2 patients, not more. And I was also sure because it needs a prolonged treatment, what side effects it will have on the others, especially a renal function.
Yeah.
And I was not very sure, so I was asking if you have any experience on that part. Fine.
So most of the supplements I showed are the ones I use. So I use ubiquinol, I use resveratrol, I use terostilbin, melatonin just recently a few patients, and of course coenzyme Q that everybody takes. So these are the ones we use, and testosterone for 20 days. That's it.
Okay, and for the do you use DHEAs and androgen simultaneously, or you pick one of it?
DHEA is androgen, so DHEA is 3 months or testosterone 20 days. Now the new T-transport trial came, the Polizos completed that transport trial on transdermal testosterone for 3 months with agonist protocol and HMG. Just what I showed, the same protocol they are using for poor responders now. So he did this huge trial which lasted for 5 years, and he is showing that there is no benefit of transdermal testosterone if given in low dose for 2 months, like DHEA if you give 60 to 90 days. But I personally feel that the dose was too less. So what we use for 20 days is almost double the dose, and I think that is what the correct dosing should be. But let's see, now again there'll have to be a trial with the higher dose.
Yeah, you
When you
mentioned
see
that
these research papers, you have to see all this also. What dose did they use? With what did they use? Which protocol they use? Because there are so many variables in IVF. It's not always easy to predict that what really benefited and what did not.
you have mentioned that the DHA should be for 60 days, okay? 60 or 90 days. Okay. Suppose patient is not conceived in that period. Do you continue DHA for the next, for how many days?
Continue till you do the egg retrieval.
Okay. Still again, there is no response. So how many days you will continue DHA?
No, not more than 6 months total. Frankly, I don't use, like I told you, I give testosterone.
Okay.
I prefer testosterone over DHA because there's a lot of evidence that testosterone worked until the T-transport trial came, but that came with half the dose.
Okay.
So as of now, it's working well for me. So I'm okay with testosterone.
Because it was mentioned in literature, they are given continuously DHA for years like that. Yeah, that's
Yeah,
why.
that was the first patient,
Yeah,
that air
first
hostess
patient, yeah.
story. Na? Yeah, she took for 3 years. And
Yes.
her 10th cycle, she had ovarian hyperstimulation at 43 with 30 eggs. First cycle, she had only 1 egg. That is that classic story which Norbert
Yeah,
Klein
this year.
told us.
But
In,
at least in a practical purposes, I think you are mentioning that it should be for 6 months only.
yeah, I think so. Because a lot of my patients are from this acting field and all, na, so they cannot. If she has even one acne, I am dead. So we have to be very,
Weight
very
gain.
careful. Very careful about weight gain, getting puffed up, breaking
Get
out.
a lot of weight gain.
These are their main
Correct.
concerns. Puffiness, all that is unacceptable to them. So
Okay.
luckily 20 days of testosterone doesn't cause any of that. So we are okay.
Thank you.
I think just all fired the questions to you and you answered so nicely. Thank you very much.
Thank you. Thank you, ma'am.
Okay, ma'am, then we can move ahead now. Do we have questions?
I don't think so. Yeah, we can go ahead. Thank you.
Dr. Sangeeta Sharma, ma'am, are you there?
Yeah, Neha, I'm there.
Yeah.
Okay. So we have Dr. Varsha Samson Roy for our next talk. She's a wonderful old friend of mine, and it's a pleasure to introduce her. She's a gynecologist as well as a qualified and one of the best embryologists of the country. She is presently the scientific director of Baby Science IVF Clinics. She has been the past president of the Academy of Clinical Embryologists, ACE, India. She's the reviewer for Journal of Assisted Reproduction in Genetics, the JAG. She's on the editorial board of Fertility Sterility, the Indian edition. She's the clinical coordinator for research on embryo viability biomarkers in collaboration with the Department of Molecular Reproduction, Development and Genetics, IISc, Bangalore. And she has articles published in national and international journals. She has also been the recipient of the Manyata Award by Manipal Hospitals, Bangalore. She headed the embryology team that succeeded in the birth of India's first IVM baby in July 2003. And she is credited with the birth of Karnataka's first vitrification baby in April 2008. She has more than 20 years of experience in the field of ART. So today she would be speaking on the lab aspects, the lab strategies for poor responders. So we welcome you, Dr. Varsha, and over to you.
Thank you. Thank you so much, Dr. Sangeeta, for the kind words. And thank you so much, Dr. Sushma, Dr. Bindu.
Welcome.
Welcome.
And
Dr. Nitin for having me here. Of course, it was a mesmerizing lecture by Dr. Jatin. He covered a lot of topics which I think me and the subsequent presenter would be doing. But thank you so much for sir for creating a very fertile ground for us. You simplified our work here. Can I share my screen? Yes, ma'am, you can share.
sure, you can share.
Yes, ma'am. Ma'am, are you facing any difficulty in sharing the screen? Yes, yes. Just give me a minute. Is it visible now?
No. You can take help of Corona people? Ruchi?
Just a second. I should be able to do it now.
You can.
Yes, ma'am.
Yeah.
Yeah.
Yeah, it is visible.
Yes. Yes, we can see.
Okay. Okay. So I will be basically dealing with the lab aspects in poor responders, the challenges that embryologists face while dealing with patients with poor response. So the objective of this presentation is basically to understand the impact of not only a low yield of oocyte here, but also the impact of the poor quality oocytes we may retrieve from these patients. and to evaluate the lab strategies to circumvent these challenges. So the main challenge here with any patient who approaches us for infertility, and all of us have witnessed this, that when we finish counseling, the first question the patient raises with us is, what are my chances of conceiving? So are there any predictive factors by which we can tell a patient, okay, you have a fairly good chance of conceiving, or you have a compromised chance of conceiving? So literature does suggest that there are few predictors, positive and negative, which may help us to not only counsel the patient, but also based on that, then have a plan in place, whether clinically or when we deal with the embryological aspects. And two of the most important factors here, which could impact the outcomes, are one, the number of oocytes retrieved, and the female age. And both these factors are very crucial to the patients of poor response. So what is the proposed mechanism in these patients? One is obviously a reduced ovarian reserve as seen in patients with advanced maternal age. And the second is reduction in the number of follicles which are sensitive to FSH. And this comes under the category of polymorphism, which Dr. Jatin explained earlier. So what mainly happens here is that there is an irreversible damage due to the oxidative stress that happens to the normal ovarian metabolism. So the incidence of a poor ovarian response patients could vary from 9 to 24%. And the variation is basically because we have varied ways of classifying or defining them. These are the two different most commonly used criteria of assigning these patients into this particular group. The Bologna criteria and the Poseidon criteria, which earlier has been explained elaborately. And one of the biggest criticism with the Bologna criteria is that it does not take into consideration the quality of oocytes while defining these patients. So we all know that this is a challenging group as far as outcomes are concerned. The pregnancy rates may vary depending on the age of the patient. In younger age group, you could see a pregnancy rate as low as 13% to as high as 35%. But as the maternal age goes up, this pregnancy rate could drop to even 1.5%. And another major risk is that there is a very high risk of cycle cancellation in these patients. So now, what are the challenges the laboratory people face with low quantity? So when the oocyte yield is low, obviously the embryo yield also reduces. Now, why does this bother us? That is because if we don't have a lot of embryos to choose from, then again, that is another negative predictive factor that our results could compromise, because basically we don't have an embryo selection criteria here, and this could impact our pregnancy rates. Also, when the number of oocytes are less, we have a higher risk of fertilization failure, and hence it increases the chances of a cycle cancellation. So now when we're looking at the numbers, we do know that age plays a huge role here. So now, what are the optimal numbers for any patient we're looking at? And this is the most talked about and most well-read paper of Sheshkamal Sunkara, wherein she's tried to identify the number of oocytes required based on the age to get a decent live birth rate. And according to this study, what is suggested is that in a younger group, you need 15 oocytes to get a live birth rate of around 40%. Now, with the same number of oocytes, if we go to older patients above 40 years of age, and we somehow magically manage to get those 15 oocytes in our Indian population, then even with the same number, our live birth rate could be barely around 15%. So which means the same number of oocytes could have a different kind of outcome based on the age of the patient. So now there are studies that obviously highlight this, that there is a positive association between the number of oocytes we retrieve and the cumulative live birth rate. That is when we calculate the fresh and the frozen embryo transfers. It is estimated that the pregnancy rate per oocyte could be around 0 to 7%, and with 4 oocytes, it could be around 11 to 18% in these poor prognosis patients. Of course, this association varies with patient age, and if the age is beyond 44 years, then irrespective of the number of oocytes, your cumulative live birth rate consistently remains low. So now in the poor response patient, what is the number of oocytes we're targeting? 15 is a very glamorous number, if I may say so. And all of us agree that though we might target for those numbers, practically it's very impossible to reach that. So what is the practical number we're looking at? And this study, which looked at the number of oocytes and the outcome, it stated that when you have obtained 5 oocytes, then you are in a better place to get a clinical pregnancy rate of at least 23% per embryo transfer. And most significantly, your chances of cycle cancellation significantly go down if you have 5 number of oocytes. So there is no significant increase in the pregnancy rate if you have oocytes between 1 to 4, but number 5 makes a difference. So probably we should try to target number 5 number of oocytes in a patient. Of course, every single oocyte matters. So now that is about the oocyte numbers. That is the number we would like to target. But what happens if, along with the oocyte quantity, the quality also is compromised? Now, let us be very clear here that it is not necessary that all the patients of poor ovarian response may also have a poor oocyte quality. It is not necessary. However, the chances of obtaining a poor oocyte quality is significantly higher in women of advanced maternal age. Now, when we talk about oocyte quality, the first thought that comes to our mind is, are there any specific morphological parameters or dysmorphisms that are peculiar to poor ovarian response patients? The answer is no. There is no specific oocyte abnormality that shows a higher incidence in patients of poor ovarian response. However, we do know that patients of advanced maternal age do show a higher incidence of oocytes with large perivitelline space, which could be because of oocyte aging. So when we talk about oocyte quality, it is not only the morphology, but also the risk of those oocytes having genetic abnormalities or being aneuploid. Now, when the oocyte quality is compromised and is added on to the less yield of oocytes, we are again increasing the risk of a fertilization failure here. Also, the embryo quality is now compromised because embryo quality is very much a reflection of the oocyte quality. Then we not only reduce the chance of embryo selection, but we also increase the risk of embryo arrest if the oocyte quality is also compromised. We also reduce the chances of getting blastocysts and blastocyst hatching. And a compromised oocyte quality not only reduces the chances of pregnancy and implantation, but also increases the chances of miscarriage. So when you have a patient of poor ovarian response and the yield is compromised, along with that, you also have a compromised oocyte quality, then that is the worst challenge that the laboratory personnel can face. Now, one also needs to bear in mind, we have spoken about oocyte freezing and all freeze cycles. We also need to bear in mind that if the oocyte quality or the embryo quality is compromised, then the cryosurvival of those gametes or embryo is also lowered. So now AMH is a routinely done test for these patients. Does it predict oocyte quality? And these two studies are done separately in both younger and older women, clearly stated that AMH levels could reflect the oocyte yield or the quantity of the oocyte. But if you look at this chart here, you will see that the AMH less than 10th percentile was one group, and AMH 25th to 75th percentile was the other group, the green group. And what this study suggested is that When the AMH is less than 10th percentile, it is only a reflection of the oocyte yield. The oocyte yield was significantly lower. However, there was no significant difference between the blastulation rate or blastocyst formation rate in these patients, nor was the aneuploidy rate different. Neither was the live birth rate after a euploid transfer different when you compare the AMH levels. Group A less than 10th percentile and group B when the AMH was within 25th to 75th percentile. So clearly AMH is not a predictor for oocyte quality, and this is something that we need to bear in mind. Now, Dr. Jatin elaborately discussed very nicely that ICSI may not be beneficial, and this is what I'm going to re-emphasize here. The biggest fear embryologist has when he or she is encountering low number of oocytes is the fear of fertilization failure. And there are enough number of studies stating that total fertilization failure is not significantly higher in case of IVF, and same stands true here. Neither is the fertilization rate different, nor is the embryo quality. Studies also suggest that even when you have a single oocyte and the male factor is normal, the chances of the percentage of fertilized oocytes and the pregnancy rates are not significantly different, whether you fertilize that oocyte with IVF or ICSI. Many a times, yes, you do have to convert these stimulated cases to IVI. Reasons could be many. So is the pregnancy rate different? And this study, which looked at patients who had 1 to 2 zygotes and were converted to IUI cycles, even there the pregnancy rates were not significantly different as compared to the ICSI cycles. And here I mention this because IUI is very much like IVF. So studies suggest that there is no benefit in proceeding with IVF in presence of only one mature follicle. However, different studies suggest that the results in cases of 2, 3, or 4 mature follicles were divergent. So do we fertilize them with IVF or ICSI? The technique of fertilization is definitely not related to the outcome as long as the male factor is normal. Fertilization failure in these cases is more related to the oocyte factor, the oocyte quality, and not the method of insemination. And we do know that ICSI cannot overcome the oocyte defects. Hence, there is no way that ICSI could provide any benefit in these cases. Now, once they are fertilized, what about the day of transfer? This is again another dilemma with these patients. So generally, we believe that where do you prefer to do a day 3 transfer? When there are more drawbacks or more risks associated by prolonging the culture. And this is one category of patients where the risk of cycle cancellation due to no embryo formation or no blastocyst formation tend to be higher in this category of patients. So do we do day 3 transfer? Do we do day 5 transfer? So how do the labs formulate their transfer policy for these category of patients? These are the different criteria. One, you could formulate your policy based on the number of oocytes. Say you get less than 3 number of oocytes, you say, I'm just going to do a cleavage stage transfer, or vice versa. So if your decision is based on the number of oocytes, then the risk you take here is that you're not taking fertilization rate into consideration, and many of these patients could have a low fertilization rate. So you might have obtained 4 oocytes, but only 1 would have fertilized. Second, do you take the decision on the day of fertilization? Now, the other side of this story is that if your decision is based on the day of fertilization, then you're not looking at the embryo quality. Then what do we do? Do we base our decision on day 2, day 3 of cleavage stage embryo and then take a call to extend the culture to day 5? This appears to be more feasible. However, this would require a little bit of more coordination with the couple. Probably the couple will have to be in the center ready for an embryo transfer in case the embryos are not good or less number of embryos have cleaved. So this is the only disadvantage, which is inconvenience to the patient. That could be a factor. Some centers also follow a blanket policy of just not checking the embryos and directly observing them on day 5. And here the biggest risk they take is of no embryo formation and high cancellation rates. And I'm not sure whether we are justified in doing this in these patients where every oocyte and every embryo makes a difference. So studies suggest that there could be similar outcomes even with 1 to 2 embryos if we proceed with day 3 embryo transfers. Some studies also suggest a higher clinical pregnancy rate with day 3 if there is only 1 transfer. Some studies also suggest a higher live birth rate with day 5 transfer in these patients. Of course, we require to take the embryos to day 5 if we are contemplating a PGTA cycles. However, the cancellation rates could vary between 0 to 28%. A study done by Cornell suggested that the chances of the risk of cancellation are higher with less number of oocytes. They are almost 30% if you have obtained 1 or 2 oocytes, and it could reduce to approximately 10% if you have 4 oocytes. So this is where the challenge of selecting the day of embryo transfer depends. This is a small study, our own patients, a study of just 48 patients, wherein we looked at embryo transfer on day 2 or day 3. We do not prefer to take it to day 5 if a PGTA is not contemplated. And we found that there was no significant difference in the embryo quality, nor the pregnancy rate, nor the clinical pregnancy rate in these patients if you are even comparing day 2 and day 3 transfers. So now, cleavage stage or blastocyst transfer, and this is a study by Crew et al. It's a recent study done in 2022, and this is a study involving 2,500 odd cycles. They looked at day 3 and day 5 transfers, fresh and frozen and cumulative live birth rates. Fresh transfers, if there is no contraindication to doing a fresh transfer, we can consider fresh transfers in these patients, as mentioned earlier. The only, I think, practical drawback here would be if the patient undergoes a miscarriage, then especially in advanced maternal age patient, you could waste another few months there to start the next cycle. But when this study compared the live birth rates, there was no significant difference whether you did a day 3, day 5 fresh transfer or in a frozen transfer or the cumulative outcomes. However, the cancellation rates were as high as 33% if day 5 transfers were considered, and a cumulative live birth of 17% was seen per oocyte retrieval, both in day 3 and day 5 transfers. So then if the challenge is of numbers alone, one of the strategies suggested has been to accumulate more number of either oocytes or embryos. And it is based on the principle that theoretically, if we increase the chances of we could increase the chances of a live birth if we are going to pool these oocytes or embryos to match a scenario like a normal responder. This would obviously give us a better power to select the best embryos, reduce the cycle cancellation rate because of no embryo. However, this puts a tremendous amount of emotional and financial burden on the couple. So if we look at accumulation, embryo accumulation or oocyte accumulation or oocyte pooling cycles, this is one of the study which suggested that it did not significantly improve the live birth rate. However, it actually increased the miscarriage rates if we go ahead with oocyte pooling. And one of the reasons given in this study was that, and we all have experienced it practically, that not all the oocytes survive oocyte freezing. So the survival rate is poor, and there tends to be studies do suggest that there can be some amount of damage to the mitochondria, to the meiotic spindle, especially during these cooling and warming cycles, and especially in advanced maternal age where already there is a high risk of aneuploidy. Any damage to the meiotic spindle could only aggravate the problem for us. So what about embryo accumulation? And this study looked at embryo accumulation in patients of different age groups, and they concluded that the clinical the live birth rate was significantly higher in accumulated cycles as compared to non-accumulated cycles in all age groups, especially in the older age group. However, there is another study which suggested that there is no significant difference in live birth rate in embryo pooling cycles. And the differences in the conclusions could be based on the different stimulation protocols used by different studies. As you can see, the earlier study looked at natural modified IVF cycles. Both these studies, however, have looked at only day 3 transfers. However, both studies concluded that the definite benefit that embryo accumulation gave was that the chances of cycle cancellation were definitely lower. So whether embryo accumulation actually improves the live birth rate is still inconclusive. Now, another aspect of this is, can we offer PGTA in these patients, especially the advanced maternal age group? And PGTA, you know, is if I may say, a gray area today. We do not know the actual benefits, though some believe that in advanced maternal age, it definitely could give a benefit of reducing the miscarriages. However, again, to get a blastocyst and a significant number of blastocysts in this advanced maternal age group, where the reserve is very poor, is a bigger challenge. So this study concluded that the same, less likely that these cycles could end up with an embryo transfer. They suggested that there was no significant increase in the live birth rate in patients who had less than 4 or fewer oocytes retrieved. The miscarriage rates were significantly lower per pregnancy. However, to avoid one miscarriage, they suggested that they had to do 31 PGTA cycles, and this puts an unnecessary financial burden on a lot of patients. So then Karaman actually compared PGTA role in poor, normo, and hyperresponder, and he concluded that euploidy rate does not directly correlate with the number of oocytes retrieved. The probability of retrieving a euploid embryo significantly reduces with advancing maternal age. After adjustment of age, the main variables that could affect the probability of getting a euploid embryo, he suggested, were the AMH, FSH, number of oocytes, and the number of top quality blastocysts that could be biopsied. So if we have to go to the stage of top quality blastocysts, definitely ovarian reserve and the response have a very significant impact, and that is where your good stimulation protocols and how the patient is managed could make a huge difference. So these findings emphasize the importance of evaluating and counseling the patients for factors both negative and positive, especially if you are counseling the patient for PGTA in this category. So now this is an interesting paper by Sandro Esteve, where he has worked on a model to predict a prediction model to suggest the number of oocytes required based on the age of the patient to get a single euploid embryo. And he has developed what he calls an ART calculator. So based on this pre-treatment, for example, in a female patient of 37 years of age, and he has different risk factors calculated here, say it is an ejaculate that is being used, this lady would require probably 11 mature oocytes as per the calculator to get a single euploid embryo. Now, after retrieval, say this lady we could obtain only 7 oocytes. So that calculator suggests that now the probability of retrieving a single euploid blastocyst in the same patient is 54%. So this could help us in counseling the patient while we are counseling them whether to proceed with PGTA or no. So finally, to conclude, a low oocyte yield and poor oocyte quality do have a cascading effect on the lab performance and the ultimate outcomes. Quality may not be affected in all cases of poor ovarian response. However, age is a huge risk factor here. Improving the yield through the process of accumulation provides greater embryo selection and reduces the risk of cancellation, but no conclusive evidence that it actually improves the pregnancy outcomes. Again, the method of insemination, that ICSI is better. There is no conclusive evidence of that. And the day of transfer, no conclusive evidence that a blastocyst transfer would yield a better outcome. However, cancellation rates are higher, especially in these patients, due to low yield, and extending the culture to day 5 may compound this effect. And no conclusive evidence of the role of PGTA in patients with poor ovarian response. Earlier, Sir mentioned about the paper of artificial oocyte activation by Sai et al. And I deliberately did not put this paper here because what that paper looks at is it mentions that oocyte activation was done in all the patients of poor ovarian response. The embryos were seen on day 3. So the outcome concluded is just the embryo quality. The paper has not gone ahead in assessing the pregnancy outcomes. So I personally feel it is too early for us to suggest artificial oocyte activation or use of calcium ionopores here in patients of poor ovarian response unless the fertilization rate in the previous cycle has been extremely poor. So that I would still wait to have more conclusive outcomes on that before AOE is recommended as another strategy in these kind of patients. So with that, I conclude. Thank you so much for your patient hearing.
Thank you, Dr. Varsha. It was an amazing talk and very beautifully the essence of this webinar actually balancing quantity with quality. You spoke on that. So do we have any questions for Dr. Varsha? I think very nicely you clarified.
Varsha, really, it was very nice. You presented very nicely with all the scientific the support. So nice.
The debate on PGTA, the extended day 5 cultures, everything you addressed so
Mention
beautifully.
all.
Conclusions which are there. So do we have any questions for her? I have a question for you that do you have any experience or what do you feel about embryo accumulation? Are you doing that? Or,
yes.
What is the criteria?
Yes, Dr. Sangeeta. So we have been doing embryo accumulation. Of course, we don't have a large number of patients there, though they do show a higher chance of live birth rate and pregnancy rate. But I'm I'm not very sure it is conclusive because it is a mixed population of both young and old patients. And we kind of do the embryo accumulation. We counsel patients for embryo accumulation only if we have retrieved at least 2 or 3 in the first cycle. So if a patient with a single oocyte in the first cycle, already they are financially tight, and to recommend another cycle for pooling, and if you don't retrieve any oocytes there, is again, I think, a tight rope to walk on. But definitely it reduces the risks of cycle cancellation. It did show an increase in the live birth rate, but not significant statistically is what I would say.
All right.
Right. But I think it will require a counseling, very good counseling for the couple also, according to the financial point of view.
Yes.
So do you use duo stim for that or 2 different stimulations?
No, 2 different stimulations, Dr. Sangeeta.
Do we have any other questions for her?
Neha, any other questions from our?
No questions.
Hello, Neha, you and Ruchi. On other link, any other questions are there?
Dr. Jatin has just given a
Message,
compliment to her. that thanks to all the organizers for a lovely meeting, and thanks Dr. Varsha for clarifying on IFSC versus IVF and role of PGT.
Thank you, sir.
Okay, welcome, Dr. Manju. We'll go ahead now.
Hi.
No questions from links.
So, Dr.
Chairpersons,
Neha, are you ready
Dr. Neha, anyone?
Yes, ma'am.
Yeah.
would you like to introduce Dr. Manju?
Yes, ma'am. Dr. Manju Jilla, ma'am. She is Director of Jilla Hospital Infertility IVF-VC and Advanced Endoscopic Center. She has passed her MBBS and MD from Government Medical College, Aurangabad. She has been trained in transvaginal sonography and color Doppler and running the USG unit of Jilla Hospital. She's trained in endoscopic surgery in 1992 and has performed successfully more than 20,000 laparoscopic surgeries. She's trained in IVF-ICSI at University of Alabama at Birmingham, Alabama, USA. She has achieved many firsts in Marathwada region, like first test tube baby, first ICSI baby, first donor egg pregnancy, and first freezing embryo pregnancy. We welcome you, ma'am.
So, Dr. Manju would be speaking on ovarian rejuvenation procedures, a very hot topic of the recent times. So, welcome, Dr. Manju, and we are waiting to listen to you.
Thank you, Dr. Sushma, Dr. Chimote, and all of y'all for inviting me today. Actually, I'm not a conference person. And after listening to two very good practical talks, we are going to go a little bit into theory, especially the molecular cell biology. I hope I wouldn't bore you much, but let's start with my slides. Screen share. Yeah, we don't want this one. We are looking at ovarian rejuvenation procedures. Right from the beginning, when we learned about the physiology of HPO axis, and like Dr. Jatin Shah was just playing with the HPO axis, how to make it work in poor responders, he was thinking more of the hypothalamus, the pituitary, the gonadotrophins to use, but actually the problem here is in the ovaries. The eggs are now much lesser than what we expect to have for a successful IVF cycle. And we all learned in our physiology that a woman has a specific number of eggs which end or which get over by the time she reaches menopause, which in the recent years has been proved wrong by certain scientists who showed that even after menopause, a good number of at least 1,000 follicles are there in the subcortical region of the ovary when a woman reaches menopause. The only thing is these are not getting activated and becoming primary, secondary, preantral, and antral. So the scientists have worked on the most difficult cases of ovarian failure. All this time we were talking of decreased ovarian reserves, but they have done work in order to make the failed ovaries start ovulating. And they have characterized premature ovarian insufficiency as a loss of ovarian function before the age of 40, manifested as hypergonadotrophic hypogonadism. That is, FSH, LH are high, but E2 levels are very low. And a woman usually comes with secondary amenorrhea, infertility, and signs of estrogen deficiency. FSH levels more than 25 IU on 2 occasions, 1 month apart, and E2 less than 50 picograms, and amenorrhea of 4 months in women less than 40 years of age are called as women with premature ovarian insufficiency. Now, the cause of this premature ovarian insufficiency causes could be many. What we spoke of as decreased ovarian reserves, it is just a period before she lands into premature ovarian insufficiency. And the causes could be iatrogenic, that is repeated ovarian surgeries like removal of endometriomas, or in cancer patients, chemotherapy, radiotherapy. Mostly the very severe ones of premature ovarian failures are patients with X chromosome disorders like Turner syndrome, X-linked single gene disorders, or mutation in the gene receptors of FSH, LH, or certain other hormone genes. Then autoimmune disorders are other common causes of premature ovarian insufficiency, like myasthenia gravis, celiac diseases, autoimmune polyglandular syndrome. 50% of women with unexplained premature ovarian insufficiency are found to have autoantibodies. Many of them have thyroid antibodies. They could be hyper or hypothyroid also. Environmental factors, reactive oxygen species, oxidative stress, use of anti-androgens. Dr. Jatin was speaking of OC pills, and many of these women, they take pills containing anti-androgens like drospirenone. And that really reduces the AMH, and these women start thinking that after OC pills they have a reduced AMH or a decreased ovarian reserves, but this is a very reversible condition once the OCs are stopped. Then mitochondrial disorders, decrease in the mitochondrial number, then dysfunction in the mitochondria. We will discuss about it later. And idiopathic cause, where most of the time a young woman comes with decreased ovarian reserves or premature ovarian failure, and we are unable to pinpoint what the reason is. It is important to know the reason because the success of therapies will depend upon the reasons. For example, if genetic causes are the cause of premature ovarian insufficiency, then they are very less likely to respond to many of our so-called rejuvenation strategies. Now, we all know that folliculogenesis is a very complex procedure. And we also know that ovary is the only organ in the woman's body which matures very fast or which ages very fast. As we also know that most of the mechanisms involved in bringing the follicle from the primary stage to secondary stage, and the number of follicles undergoing atresia in this period, what are the intrinsic factors that are playing a role in the ovary, is much of it is still unknown. But it is known that the initial recruitment of the primordial follicle is linked to protein kinase B, that is AKT, activators of this pathway, and mammalian target of rapamycin, that is mTOR signaling pathway. So these are the intracellular signaling pathways which stimulate the nucleus and activate it towards becoming, or the oocyte or the primordial follicle becoming primary and then secondary. As Dr. Jatin Shah already said, that we know that at 22 weeks, we have around 6 million follicles in the ovary. By birth, reduced to 2 million. At puberty, just 4 lakh, that is 400,000 follicles are available. And every menstrual cycle, 1,000 follicles start going towards becoming primary, then secondary. And many of them are lost on the way. And only one follicle ovulates in the end. So in her reproductive life, only 400 follicles ovulate, all the rest undergo atresia. And by the time of menopause, she has just about 1,000 primordial follicles left in the ovary, but they are still there. And that is the principle used for rejuvenating ovaries which have failed. So if we look at this diagram, it is these follicles, the antral follicle and the pre-ovulatory follicles, in whom the atresia can be stopped because they have receptors for FSH, and giving higher doses of FSH will prevent atresia of these follicles. And that is our principle of ovarian stimulation in controlled ovarian stimulation for IVF, where we keep the dose or the level of FSH and LH high so that the follicles do not undergo atresia. But what is there that prevents or causes atresia of a primordial follicle when thousands of primordial follicles are becoming primary? Hundreds of them are dying before they become secondary, and hundreds of them are dying before they become AMH producing follicles. What exactly is happening there? The exact physiology is still unknown, and therefore we are using many strategies of regenerative medicine in reproductive medicine today in order to regenerate or rejuvenate the primary and the secondary follicles, prevent them from undergoing atresia, and get a few number of follicles required for her reproductive process. So the strategies for POI, if not interested in fertility, we know these women are hypoestrogenic and they should receive HRT. But those interested in ovulation, we have different ovarian rejuvenation procedures. And one of the most important and most spoken of and a popular paper by Kuwamara from Japan was that he showed that after menopause, we could activate the primordial follicles and bring about ovulation in women after menopause. That is called as in vitro activation. What is the mechanism of IVA? We will see later. Similarly, we know that as a woman ages, as we age, almost in every cell of our body, our mitochondria number decreases or our mitochondria become dysfunctional, and probably the telomerase activity decreases because of dysfunctional mitochondria. And so bringing the mitochondrial activity back to normal is one of the strategies used in POI patients. We know that our stem cells secrete many growth factors, many factors which change immunity, which improve the vascularity, decrease the fibrosis in the organs, and they do this through their exosomes. So using stem cells and their exosomes in the ovary, either by putting them in the ovarian or through ovarian artery, or by directly injecting them into the ovary, we may be able to rejuvenate the primordial follicles or prevent their atresia. We know that when we inject stem cells in other places than their place of origin, they usually die in a short time. To prevent their death, addition of biomaterials like collagen, alginate, and hyaluronic acid has been used in the ovary for rejuvenation. Since we know that the secretions of the stem cells are more important than the stem cells themselves, newer therapies like a simplified therapy of intra-ovarian PRP, that is platelet-rich plasma, which is extremely good or which contains a lot of growth factors, anti-inflammatory, or immunoprotective mechanisms, PRP has turned out to be one of the simplest way to rejuvenate the ovaries, giving very good results, as we will see in the further part of the lecture. So in short, primordial follicles can be activated in vitro or in the ovary with decreased ovarian reserves or premature ovarian insufficiency. Stem cells can be used, exosomes of stem cells can be injected, stem cells can be injected with bioactive materials like alginate, hyaluronic acid, and collagen, so that the life of stem cells in the ovary increases. Mitochondrial functions can be improved either by drugs, by mitochondrial transfer in the laboratory, or we just spoke of the medicines used for improving the mitochondrial health, that is similarly, the best, the easiest, and the most tried nowadays is platelet-rich plasma, which can be injected directly in the ovaries by transvaginal ultrasound or by laparoscopy. So let us understand the first method, that is IVA. In vitro activation mainly involves these cell mechanisms, that is these signaling molecules in the cell, that is P10. P10 is an inhibitory protein in the cell which inhibits the activation of primordial follicles, whereas PIK3 increases the activity of primordial follicles. So these concentrations, or inhibiting P10, increasing PIK3 and inhibiting PIKB, ACT and FOXO3. FOXO3 actually, hyperphosphorylation of FOXO3 goes to the nucleus and stimulates the nucleus of or activates the nucleus of the primordial follicle. This is what the Japanese scientist Kuwamara used in his experiment. He made small pieces of the ovarian cortex and he put these substances in his culture media when he cultured these cortical pieces for 2 days, and after that reinserted that into the serosa below the fallopian tubes. So a chain of events, that is that hyperphosphorylates FOXO3, which enters the nucleus and triggers the primordial follicle activation, was done by Kuwamara. AKT also phosphorylates other pathways, that is tuberous sclerosis, which inactivates TCS1, TCS2 complex and induces mTORC. mTORC is very important for the primordial follicle survival. Actually, we should understand a little bit of molecular cell biology in order to understand these pathways. So to simplify, on the surface of the cell, we know this is a lipid and a protein or lipoprotein membrane. There are a lot of receptors. So there are 7 transmembrane receptors. There are tyrosine kinase receptors. So if we say that this is the cytoplasm part and this is the cell membrane, here is a this is a tyrosine kinase receptor. So the growth factors from the stem cells get attached to the tyrosine kinase receptor, which stimulates PI3K and which gets converted to PIP2, that gets converted to PIP3. Now this conversion of PIP2 to PIP3 is inhibited by P10. As I said that P10 is a inhibitor of primordial follicle activation. PIP3 then activates AKT and AKT causes phosphorylation of FOXO3 which enters the nucleus and the primordial follicle gets activated. Similarly, mTORC also prevents the atresia or the death of the primordial follicle. Now, the second part is the hyposignal, which we will see later, what happens in the hyposignaling. So we all know that all our body organs maintain a size. The liver maintains its size, the brain maintains its size, the ovary maintains its size. This is because the cell proliferation is inhibited when there is the capsular pressure on it. The capsular connective tissue or collagen produces pressure on the cells, which is called as a hyposignal. And with this pressure, inside the cell cytoplasm, there is a yes associated protein called as YAP and there is a TAZ. Both of them are inactive. Whenever the pressure is released, these YAP, TAZ enter the nucleus, disrupting the hyposignals through ovarian fragmentation, increases polymerization. So that pressure is changed. G-actin is converted to F-actin and YAP, TAZ enter the nucleus and they activate all the transcription factors and activate the primordial follicle. So the first experiment by Kuwamara et al. Performed laparoscopic removal of ovarian cortex. They fragmented it in the lab. They took it in the dish, Petri dish, which we use in IVF, and they cut it with a knife into 1 to 2 cubic millimeter pieces. Then incubated them with AKT stimulators for 2 days and transplanted these pieces in the serosa under the fallopian tube. They were followed weekly. These patients were then followed weekly to see presence of follicles. And once follicles were seen, IVF was done. 2 out of 5 patients achieved a pregnancy. These were patients with premature ovarian insufficiency. That is, they had almost reached menopause. The second experiment, now in the first experiment, you had to do laparoscopy 2 times. First time, duoscopy, remove the ovary or remove the ovarian cortex. Then after, keeping it in the laboratory for 2 days, the pieces with AKT stimulators, redo a laparoscopy and insert it into the peritoneum below the fallopian tube. The second experiment was, they said that there is no need of AKT stimulation. Just the change in the hyposignals will bring about all the change that we require for activation of the primordial follicles. So what they did was, they took out the ovarian cortex. Then in a short time, they quickly fragmented it and then they reimplanted it in the other ovary at the same laparoscopic procedure. And 4 out of 11 patients achieved a pregnancy. And 4 had cryopreserved embryos. So this showed that this was a very effective technique, that is disrupting the hyposignals in the ovary. So this is the first experiment. That is, they removed the ovary, they cut it into small, the cortex was removed and cut into small pieces and then cultured for 2 days with AKT stimulators and then with the second laparoscopy reinserted in the peritoneum below the fallopian tube. The second experiment was that they just, in the first laparoscopy, removed the part of the cortex, a piece of the cortex, cut it into small pieces and inserted it into the other ovary during the same laparoscopy. So only 1 surgery was required. So this is the oocyte activation or the primordial follicle activation techniques, which consists of 2 things, that is adding AKT stimulators or reducing the hyposignals. Now we also said that as the ovary ages, or as in all these patients with premature ovarian insufficiency, the mitochondria become ineffective, or they are decreased in number, or they become dysfunctional. We all know that mitochondria are the power sources of the cells, and they contain their unique genome. The mitochondria has its own genome. It does not depend on the nuclear genome. This is a circular genome, and it contains 37 genes, and mostly that is required for production of ATP. And we all know that the primordial follicle has a great job of doing meiosis, that is actually pulling the chromosomes apart in an equal number, that is half one side and half other side. And as a woman ages, we know that this becomes ineffective because mitochondria are decreased, or the mitochondria become dysfunctional. So the number of mitochondria, or the health of mitochondria, it is tightly linked to the oocyte quality and the embryo development. Ovarian aging caused by mitochondrial dysfunction, like decrease in mitochondrial number, stand breaks, mutations, causes excessive collection of reactive oxygen species in the oocyte. And these ROS lead to telomerase shortening. The telomerase enzyme shortens, and that is why POI becomes very common in these patients with mitochondrial dysfunction. And the mitochondria, like the DNA in the nucleus, it is protected by histones. There are no histones in the mitochondrial genome, and therefore it is more likely to undergo mutations. So what do we do to bring the mitochondrial health back to normal to some extent in these patients with decreased ovarian reserves? So the pharmacological methods are use of coenzyme Q10, resveratrol, melatonin, and rapamycin. They restore mitochondrial vitality. Just as we spoke, coenzyme Q10 is a component of the mitochondrial electron transport chain and a cellular antioxidant. Resveratrol, an anti-aging compound, slows down ovarian aging by removing the senescent cells, the dead cells. It acts on the sirtuins. These are new molecules which are found, and they are supposed to clean away the dirt in the tissues. Melatonin is an antioxidant in mitochondria. It maintains telomerase activity and activates sirtuins, the same thing again. And we know that certain laboratory experiments are also done to improve the mitochondria, like transfer of mitochondria. You may take mitochondria from stem cells and transfer it during ICSI in an egg, which you feel is of an aged woman, or we feel that there are less mitochondria, or poor premature ovarian insufficiency stimulated patients. You can also add mitochondria to their cytoplasm. Or we know that the 3 baby was produced by taking a 2 pronuclea, removing it from an older age woman's egg, and then putting it in a younger egg by removing the pronuclei or a GV egg of the young woman. So we actually use cytoplasm of a young woman and nucleus of an older woman. So that is a mitochondrial transfer, which is a laboratory procedure which can be done in patients with POI, where we think that there is a high chance of mitochondrial dysfunction in these patients. Now, stem cells, a lot of work is being done in the stem cells in the world, but a lot of humbug things are also happening with stem cells. So we should be very careful when we listen to stories about stem cells. And stem cells have been used by orthopedicians, by neurosurgeons in regenerative medicines. And we all know that they have a lot of ability to regenerate cells. So stem cells are early undifferentiated cells with the ability to self-renew. They have unlimited proliferation ability, and they can be differentiated when we put them into different transcription factors. When we add different transcription factors, we can differentiate these stem cells into different cell lines like myocardial stem lines, neurons, or even primordial follicles. Now, they can be classified into embryonic stem cell lines, adult stem cell lines, or induced pluripotent stem cell lines according to their origin. Mesenchymal stem cells, which we are using in ovarian regeneration, they are a subset of adult stem cells. They are isolated from different tissues, commonly the bone marrow, which is rich in stem cells, adipose tissue, which is easy to derive, menstrual blood, still easier to derive, umbilical cord can be got very easily, amniotic fluid, and amniotic membrane, and placenta. All of them are very good sources of mesenchymal stem cells. So what do the stem cells do when we inject stem cells in the ovary directly or through the ovarian artery? They they produce homing. Homing is that they go and sit there. Then they get differentiated. Some of them can get differentiated into germ cells. That is what is a theory, but not proven. The most important thing that they do is their paracrine effects. That is, they produce angiogenetic, anti-apoptic, anti-fibrotic, and immunomodulatory substances or molecules, which help in prevention of atresia of the primordial, primary, and secondary follicles. They produce all their effects by paracrine secretions. That is, these cells secrete substances. So they are actually locked in the exosomes, small vesicles inside the stem cells. So it is seen that if you take these exosomes instead of taking the stem cells, you get the same effect that you would get with the use of stem cells. And you can also use the mitochondria in the stem cells to transfer into an oocyte. So that is the use of stem cells in ovarian rejuvenation. So mechanism is stem cells exert their effect by homing, differentiate multiple bioactive molecules like growth factors, cytokines, regulatory factors, signaling peptides. These paracrine stimuli improve the damaged ovaries by anti-apoptic, anti-fibrotic, angiogenic, anti-inflammatory, and immune regulatory pathways. Stem cells secrete exosomes to mediate their paracrine signals. Exosomes contain mRNA and microRNA, which further improve the ovarian regeneration procedure. Stem cells mediated mitochondrial transfer, as I just spoke, also helps in improving the quality of oocyte and the embryos. Now, what are the sources of stem cells and how do we achieve it? So amniotic fluid, mesenchymal, and epithelial stem cells, this is how we get them. I will discuss later. But when they are injected in the ovary, it is seen that they restore AMH and decrease FSH level. Then when they are stimulated with pulsed ultrasound, they still work better by increasing the weight of the ovary. This has been proved in animal experiments. Umbilical cord mesenchymal stem cells restore ovarian morphology, elasticity, and function. And it's not embryonic, it's amniotic membrane stem cells secrete IGF-1, VEGF. All these are growth factors, GDF9, LIF. They increase microRNA levels, FOXL2, OC, BM, bone marrow, bone morphoprotein 15, and hyaluronic acid synthetase. All this is produced by the amniotic membrane stem cells and placenta-derived mesenchymal stem cells. After intravenous application, they increase transforming growth factor beta, decrease INF gamma. These are all involved in inflammation. They improve and cause follicular activation by PI3K-AKT pathway. Now, the important thing is any amniotic fluid membrane, they have very low immunogenicity. These mesenchymal stem cells have low immunogenicity, and you can take the stem cells of membranes of any patient and you can inject them in the ovary because they do not get rejected. Similarly, it's very easy to get human menstrual, the same patient's human menstrual blood stem cells can be, mesenchymal stem cells can be separated and cultured in the laboratory to get the adequate number of stem cells, and then they can be injected directly into the ovary or through the ovarian artery. Adipose tissue stem cells, nowadays more work is being done because it's very easy to get them, and stem cells injected directly in the ovaries or intravenous through intravenous flow can increase the ovarian angiogenesis. And the best is bone marrow derived stem cells. It's easy for us, all of us, to use bone marrow stem cells because just take out about 15 ml of bone marrow from the iliac crest, then centrifuge it, remove the RBCs, you get, by density gradient, you get the layer of mesenchymal stem cells, and these can be aspirated and directly injected into the ovary by laparoscopy. Many times you need not culture the bone marrow derived stem cells, so that simplifies the procedure, makes it easy for clinicians to use. So how do you isolate one of the papers where people are doing this procedure regularly? They get an ethics committee approval, and then 45 to 60 ml of bone marrow is aspirated from the patient's iliac crest under general anesthesia, maintaining strict asepsis. And they use this, all these hematologists know how to take out the bone marrow with this GemCD needle. They collect it in CPDA medium using 1 ml of medium for 7 ml of bone marrow and centrifuge. And just like we separate cells by their density gradient, these mesenchymal stem cells are separated and they can be directly injected into the ovary by laparoscopy. Similarly, how do we isolate the mesenchymal stem cells from the amniotic membrane? So after we deliver the placenta during a cesarean section, on the soft surface of the placenta, the membrane is scraped out, and then it is cut into 1 to 2 centimeters pieces, put into a 50 ml Falcon tube, and then it is digested with trypsin and collagenase mixture in tuberculose Earl's modified media. Then it is mixed thoroughly and centrifuged 1 to 2 times. The trypsin digestion removes the amniotic or mesenchymal stem cells from the amniotic membrane, and then these are further cultured to increase their number or directly injected into the ovarian vessels. So the summary of treatments done to improve or to increase or to treat POI is reactivation of the dormant follicle, which we saw in Kuwamara's experiment. That is P10 inhibition and PI3K activation. What it does is it induces follicular growth. Amniotic fluid stem cells, they decrease inflammation, decrease FSH, increase AMH, increase estrogen, and increase hyaluronic acid synthetase. And they prevent follicular atresia, decrease tissue injury, and it has an anti-inflammatory effect. Similarly, umbilical cord stem cells increase angiogenesis, decrease FSH, increase AMH, and they cause proliferation of granulosa cells, induce follicular growth. Human placental stem cells have a similar function, increasing the blood flow to the ovary. Human-derived menstrual blood stem cells, they cause induction of cell proliferation, stimulation of regeneration, and inhibition of apoptosis and fibrosis. Adipose stem cells have similar effects, and bone marrow stem cells also prevent follicular atresia and induce angiogenesis. So these are all the stem cells and the mechanism in which they act. The various studies have shown different success rates of use of stem cells or use of different techniques of premature ovarian insufficiency treatment. So traditional in vitro activation by Kuwamara showed laparoscopic, we all know the procedure, 27 POI patients, and out of which 2 pregnancies they got initially. Similarly, the single-step laparoscopic hyposignal disruption, 11 POR patients, 4 pregnancies. Then umbilical cord mesenchymal stem cells done by Ding et al. Intra-ovarian direct injection, 14 POF patients, 2 pregnancies. So overall, we are seeing that when they are using stem cells, they have a little lesser pregnancy rates. See, 30 POF patients, 1 pregnancy. Then here, this was a good autologous bone marrow stem cell therapy where they did intra-arterial catheterization, 15 POR patients, 5 pregnancies. But better results have been achieved with PRP, which we will soon discuss, where we see that with PRP here, non-surgical transvaginal ultrasound-guided PRP, 3 POR patients and 3 pregnancies. So let us see what we are doing further with PRP. So treating POI with the exosomes is associated with higher clinical safety. Exosomal microRNA separate. Exosomes are actually, we disrupt the stem cells. We get their secretions and then transfer that or directly inject that into the ovary. Exosomes can be derived from bone marrow stem cells, adipose stem cells, amniotic stem cells. Exosomes treatment for POI proves that stem cells act through their paracrine factors. The only thing is when we put stem cells and stem cells remain in the ovary, they act for a longer time, and exosomes of PRP act for a shorter time. So in order to increase the life of stem cells inside the ovary, biomaterials like alginate, hyaluronic acid, or collagen are used so that stem cells can be retained and they can live for a longer time into the ovary. The problem with stem cells is that they can become tumors, They may have immunological rejection sometimes, because when we start growing them, they may develop immune tendencies, and they're heterogenic. So there are many challenges to put the stem cells inside the ovary. So a simpler method, we know that it is the growth factors coming out from the stem cells which activate the ovary. The simpler method is actually infuse platelet-rich plasma in the premature ovarian insufficient ovaries. PRP contains high concentration of platelets, and its efficacy depends mainly on the alpha granules of the platelets. Alpha granules of platelets are rich in growth factors, and PRP promotes development of primitive primary follicles, restores ovarian microenvironment, reduces oxidative stress and atresia. So how do we do this PRP procedure? We take 40 ml of patient's blood in a vacutainer, ACDA, centrifuge the sample at 1500 RPM for 15 minutes, take 15 ml sterile conical tubes, take supernatant. That is, the only thing is to remove the RBCs. And we take the supernatant and then again centrifuge it to remove the WBCs, and only take the platelet layer, which we give immediately to the operation theater, where by transvaginal ultrasound or by laparoscopy, the PRP is activated with calcium gluconate or calcium chloride and then injected into both the ovaries at multiple sites. So here at Jilla Hospital, we have made certain modifications in ovarian rejuvenation procedures. Of course, we've taken a ethics committee approval, and all patients with AMH less than 1.1 and age less than 40 have been included in the study. In the study, we give GCSF 2 days prior to laparoscopy, and laparoscopic injection of activated autologous PRP is done in both the ovaries, along with injection of HCG 2000 IU intraovarian. And then we also cut the ovarian cortex locally. Just the surface is cut with the laparoscopic scissors, and the ovary is thoroughly washed. Postoperatively, we give androgel, CoQ10, steroids, and antibiotics. So I can just show you the procedure in short. So this is how PRP is being injected in the ovary at multiple sites. Sometimes you may just go through and through, so you have to avoid that, because these ovaries are quite wrinkled and tough. And the next part of the procedure is taking small nicks on the surface of the ovary, the hyposignal disruption. So instead of taking them out, making the pieces and again reinserting it in the ovary, the idea is just take small nicks and then thoroughly wash the ovary. Now, we have not actually compiled all our results when this talk came up, so I'm putting the raw data. In our study conducted, we evaluated the effect of PRP and hyposignal disruption and gonadotrophins in infertile females with AMH less than 1.1. 150 patients underwent this type of a laparoscopic ovarian rejuvenation procedure. 1 to 2 days prior, they received GCSF injection subcutaneously. And post-laparoscopy, they received androgel, CoQ10, vitamin supplementation, and steroids. Patients who are followed on day 2 of the first, second, and third menstrual cycle, our raw data suggests that more than 70% patients had an increase in AFC by at least 4 to 6 follicles in both the ovaries. That a patient who had an AFC of 3 gave us at least 8 to 10 eggs after stimulation in the next second or the third cycle. Our study suggests that local disruption of hyposignals along with injection of activated PRP, growth factors, and gonadotrophins improves ovarian reserves in women with low AMH. Our raw data also suggests that AFC increase is higher in women where AMH is between 0.5 to 1.1. But if AMH is very low, less than 0.2 4, and the lower it is, lesser is the success of PRP and hyposignal reduction. That is, the rise may be just by 1 or 2 follicles. We have not tried to find out the exact cause of POI in our patients. However, those very young patients with extremely low AMH could be having a genetic cause of POI, and that is why may not respond very well to ovarian rejuvenation procedures. Thank you.
Manju, it was really wonderful. Very good study. Really, very nice.
Yeah, it was a wonderful talk, Dr. Manju, and in very depth you discussed all the different ovarian rejuvenation techniques which are there. And basically, it was your own experience which was reflecting.
Yeah, much of it is theoretical.
No, Manju, it was very nice, Dr. Manju. You spoke so well and doing fantastic thing.
Right. So,
I think
what are the approvals or the licenses which are required for the stem cell harvesting?
actually, as on today, much is not available. We are not doing stem cells here because much of stem cell work now we have realized that it is the exosomes in the stem cells which are active. So why go into that complicated procedure of harvesting stem cells and going into the passages? All that, just take the activating factors which we can easily get through platelet rich plasma.
Yeah, it's a very practical aspect. Yeah.
Yeah, because they have used the spent culture media of the stem cells and injected that in the ovary, getting similar results. So they realized it is the secretions of stem cells which are more important than the stem cells themselves.
Yeah, in one sitting you are conducting everything. Yeah, it's so nice. In one laparoscopic procedure.
Hello.
Yeah.
Hello,
It's in a
Dr.
single laparoscopy procedure. Once the
that's very
patient
nice.
has decreased ovarian reserves, hysto, lapro, tubal evaluation, ovarian rejuvenation, all can be done together.
Do you have any experience with transvaginal intra-ovarian installation of PRP, or mostly you are doing it?
I'm mostly doing, because see, we do laparoscopy prior to any treatment of infertility. So once we know that AMH is low, that is done with laparoscopy only. But we have some patients who have already done laparoscopy elsewhere and they do not want to go in for a laparoscopy. So we can perform a transvaginal, like pickup. But here we, for the laparoscopic ovarian PRP, we take around 4 ml of PRP. But in the transvaginal, I think it is better to take lesser quantity. We ask them to concentrate it a little more and just take 2 ml, 1 ml this side and 1 ml the other side.
Technically must be difficult, na? Vaginal. Technically must be difficult because it's
yes, actually laparoscopy is very safe because you actually hold the ovary and then inject it.
Sometimes the ovary may be at a higher level, so it may be difficult to. Yeah.
And it is small, it may just move away with the needle. So
yes, Dr.
Many people in the world are doing it only by transvaginal ultrasound. They are not doing it with, and the aim of giving GCSF is it stimulates the bone marrow and it actually doubles or triples the number of platelets in the blood. So that is it. And steroids are because many of our young POI patients are autoimmune. And many women have hypothyroid, hyperthyroid, they have anti-ovarian antibodies. So that is the reason of giving steroids, that is to bring that down. Coenzyme Q10 is for the mitochondrial activity, and we all know that androgens improve the ovarian reserves.
I think Dr. Neha has a question to ask.
Yeah, Dr. Manju.
Tell me.
Yes, it was a wonderful lecture, and I think all these things should give some hope to our so many young patients with the poor
now that donor eggs is out of question.
And even the patient themselves do not want donor. They are so highly educated girls coming. We also suggesting them donor becomes quite painful. I just wanted to ask which needle you are using for the installation of PRP laparoscopic.
Oh, simple spinal needle.
Spinal needle. Okay, fine.
18 to 20 gauge number spinal needle.
And do you find many of the times when you inject the PRP, sometimes it's reverts back?
Not really all the time, but we have almost 4 ml, so adequate goes in the ovary.
For adequate dose.
Yeah, and honestly, we have got lot of follicles in some patients, with a AMH of less than it was around 0.6, and
Yeah.
we've got 18 follicles in her.
Follicles in her, yes.
And her previous stimulation, she used to get only 3 or 4.
Yeah, I think it definitely, we also experience that it definitely gives, and sometimes even the number is not more, but the quality has improved. And you
Yeah.
get better quality of blastocyst and the success rate also.
But I feel this hyposignal disruption also helps.
Yeah. I just wanted to ask you, when we have injected the PRP and after that when we do this cutting of the cortex, is it like whatever we are injected is likely to come back?
No, it doesn't come out because what we are cutting is just the cortex, and where we have injected is inside the tissue, inside the ovarian medulla.
Ideally speaking, we are supposed to inject it just below the subcortical level where the
No, this is fluid. No, it goes everywhere.
Yeah, it goes everywhere.
Everywhere, yeah.
And I think the location of the cuts may be different, no? Slightly different. Where you are injecting.
Just the surface. See, this, no one in the world has done it. We are the first people to try, because we said why they are taking it out and again reinserting it, and they are cutting it in the dish. Why don't you cut it inside only?
Yes.
That's the only difference, nothing else.
Good logic.
Yes. I think yes, it is a wonderful. And
you thoroughly wash the ovaries so that adhesions are not produced.
Yeah. And will you like to stimulate them after how many weeks?
No, immediate next period we start stimulation. We do a transvaginal ultrasound, see what is the AFC. Usually the AFC definitely has increased, we start stimulation.
Okay, once your AFC count has
increased. Yeah. And most of these patients, we call them on the second day of cycle, but prior to that, we also give them synchronization medicines for the last 5 days. We give them estradiol valerates. And we give estradiol valerates sublingual.
Sublingually?
Yeah. It is not destroyed in the liver, first bypass. It nicely goes in the blood. Levels are well maintained, and we never get any erratic follicles with that. Last 5 days of the cycle.
Okay. Great.
Yeah. Even for our endometrial preparation, all our Progynova is given sublingual.
Okay.
So what about your experience on transvaginal estradiol preparations?
I'm telling you, I've done very few of transvaginal what? Estradiol preparation.
Yeah.
Actually, I'll tell you what, this estradiol valerate needs lot of fluid to get absorbed. And the vagina in these patients is not very, doesn't have too much fluid. Below the tongue, they get better absorbed with sublingual.
Good idea.
But nowadays, we prepare the endometrium more with letrozole in patients who are coming for frozen embryo transfer. We feel that gives a continuous supply of estrogen to the patients.
Right.
Letrozole, you give it for how many days? For the endometrium?
5 days. 5
days only. And you wait for a folliculogenesis?
Yes. We look at the follicle. The follicle will rupture on day 6. Look at the follicular size. We get a lovely triple endometrial echo, and then you may give a rupturing, or you may start progesterone next day.
Okay. And you wait for the rupture, or even suppose the patient doesn't rupture, if the follicle goes into the LUF, still we like to go ahead with the embryo transfer?
I think you can measure progesterone and see what's your opinion, Dr. Manju, on that.
I feel that if I don't do progesterone level.
Okay.
Before the time of rupture, you may do, but I don't think with letrozole you are going to get a high progesterone prior to rupture.
I just meant to confirm the ovulatory status. So you use an ultrasound for that, basically.
Yeah. We just like like you do a follicular study, you start seeing her from the 12th, 13th day. Because please, I thought this was very, very theoretical, so I was wondering what
But
to
it was very nice. Really well covered. I think
Chalo,
we'll have
thank
one
you.
group photograph before leaving, and we'll have a vote of thanks also.
Yes,
So
ma'am.
be here. Ruchi?
I mean, I'm back here, Sushma madam.
Okay, yeah.
Yeah,
Please
ma'am,
do the
if
disclaimer,
we
no?
want a photograph, please, stop the screen share,
Please
then we
stop
can have a,
sharing.
yeah.
Yes, I have stopped.
And
Yes,
by
yes,
the
ma'am. I
time
have stopped.
the photograph is being taken, let me just say one thing. It was when we decided to have this webinar, it was all about quality. The emphasis was on quality, whether it was the speakers, the chairpersons, and of course, we are as IVF people in the field of IVF, it was about the quality of oocytes and embryos. And all our speakers and chairpersons today have justified that quality is not just by accident, it is a result of very intelligent efforts, and we have had such intelligent speakers here who have thrown light on the various aspects of how we can enhance the quality of oocytes and embryos that we get. I mean, poor responders are going to be there. They are, I mean, the maximum load of patients that nowadays come is poor responders. But then within those poor responders, what is the best possible thing that we can do to increase the quality and increase our take home baby rates? And I'm immensely thankful to all our speakers who have, I mean, they have all spoken by experience, by research. Dr. Manju madam, I mean, it was so wonderful to see how you have come up with your own research as well. Dr. Varsha, of course, I mean, a very experienced embryologist whom people like us look up to for guidance also. And of course, Dr. Jatin, I mean, all aspects of poor responders, be it from the stimulation protocols, be it the pre-treatment, be it the post-treatment, be it the laboratory aspects of how you go about dealing with poor responders, every single aspect has been dealt with very nicely. And we are fortunate to have such wonderful chairpersons in Dr. Sangeeta Sharma and Dr. Neha Lad, who added to I mean, qualitative factor of today's webinar by asking such wonderful questions as well. And so many thanks to all our faculty. Jatin, Dr. Parsha, Dr. Manju, our chairpersons, Dr. Neha Lad, Dr. Sangeeta. Many thanks to our wonderful MOCs, Madha and Neha, for carrying out all the proceedings in such a smooth manner. And thanks can never be enough for our wonderful secretary, Dr. Sushma Deshmukh, madam. So thank you so much, ma'am, for being, for being all that you are, a multifaceted personality. And of course, last but not the least, many thanks to Corona Remedies for always providing us with a wonderful platform, for giving us all the support in all the webinars that we do. And 30 webinars speaks a lot. I mean, to have 30 webinars and with such wonderful audience and attendance. So yes, you all add to the quality of our webinars. Immensely thankful to each one of you for being there, and thanks to the delegates also. I mean, we have definitely, to begin with, we had 300 plus delegates. So now
This I wanted to mention. It
yes,
was a grand beginning of New
yes,
Year.
it was a grand beginning, and
More
let's
than
see, we'll get the final figures.
person were there since beginning.
Yes.
Logged in.
Yes. So for a webinar, that's a huge number. So, and it is all due to all the collective efforts as team members of IFS Vidarbh chapter as well. So, and NOGS for associating with us in all the activities. Now we are doubly benefited because of Sushma madam being the president of NOGS as well. So thankful to each one of you. Thank you so much.
Thank you.
Yeah. Varsha?
Really, all did very well. All speakers, wonderful.
Yes.
And Neha, Swada, you also did very well.
Absolutely.
Thank you so much, ma'am.
Absolutely.
Ruchi, photograph done?
Dr. Sushma,
Yes,
madam,
ma'am.
it
Yes,
was
ma'am.
really very interactive.
Bye.
Yes.
Thank you. Very
Thank you.
interactive.
Thank you.
Thank you so much.
Thank
Thank
you.
you so much.
Thank you.
Bye. See you.
Bye.
Thank you, Sushma ma'am.
Thank you. Thank you very much for
Thank you
gracing the
everyone. Thank
orchid
you,
on
Dr.
gracing.
Bindu ma'am.
Thank you. Thank you. So we missed Nitin sir, but
Yeah.
we'll have him next time.
He was
Yes.
stuck in the lab. Our
Yes.
senior embryologist is not there. Her daughter has delivered, so he has to take all the
Oh, okay.
No. I mean, it is this way
But
or
you
the
covered it. You covered it
the
very
other side of
nicely.
the coin for
Gracefully
us.
you
So
covered.
yes, good.
Thank you,
Thank
ma'am.
you so
That's
much.
why I put the word dedication for you.
Yes.
In my ABC, dedication.
Yes.
Dedicated chairpersons.
Okay.
Dedicated and efficient.
Yes.
Thank you. Thank you so much. Good
Thank
night.
you. Good night, ma'am. Good night.